good morning everyone. So welcome to day 1 of the surgery visual fest. Just a minute. Hi, good morning everyone. I hope it's clear. Audio and video is there. Is the audio and video clear to everyone? Just wait. I'm not able to see it my phone also. Just 1 minute. Yeah. Okay. So welcome everyone to Surgery Dada. So today what I have decided that in this visual fest I would be selecting all the top notch images of surgery and we'll be giving some respected time, dedicated time to each image, and we'll be discussing 5-6 points on every image. So this is going to be a lengthy session. I'll try to cover almost more than 100 images and the image based concepts. So without wasting time, let us start with this, and I would be more than obliged if you will also answer. So the first question is related to a foreign body in the neck and there is a penetrating injury of the neck. The next thing is what zone this injury belongs to and what is the management of this. Remember, when we talk about the zones of the neck, it is what is very important, that zones of neck are defined by a classical orientation. What is that? I'll go to the next page and there I'll discuss that. So when we talk about the zones of the neck, yes, it is the clavicle, or we can take the level of sternum, and then again this is clavicle. So from the clavicle up to the level of mandible and the base of the skull, we have the zones of the neck. Now when we talk about these zones are further subdivided from the sternum or clavicle up to the level of cricoid, this is zone 1. From the cricoid up to the angle of mandible, this is zone 2, and from this up to the base of the skull, we have zone 3. So there are 3 zones which we know. Zone 2 is the muscular zone. Zone 1 and zone 3 are to some extent hidden by the bony cages. So surgeries in the zone 2 are very easy, but zone 1 will require a sternotomy, zone 3 will require a mandibulotomy. So if we see, this injury belongs to what zone, students? This injury belongs to zone 2 because this is where the zone 2 is. So this injury belongs to zone 2. What shall be the management for this zone? It is very simple. Whenever we have a patient of neck injury, the very next thing that you need to understand is the hemodynamic status of the patient. There could be 2 possibilities. The patient shall be hemodynamically unstable or the patient may be hemodynamically stable. When we have the patient unstable, we need to decide that we shall be going for surgery, but before we go for surgery, we need to understand what zone the injury belongs to, because if the injury belongs to zone 2, surgery is the next feasible option. But if it belongs to zone 1 and 3, before you go for surgery, you have to think twice or thrice, because you need a mandibulotomy or sternotomy, which is a time consuming, cumbersome process. And therefore the first line is you have the angioembolization for these patients. So for 1 and 3 unstable patient, angioembolization with the help of an intervention radiologist is what is done. If it fails, yes, you will have a call for surgery. Now remember, if you have stable patients, there could be a possibility that there is no injury, or there is a possibility that the injury is there but it is still not evident clinically. So in that case, you will have to you will have to just recognize the pattern using a CT scan. Remember, the conventional CT will miss the vessels, and therefore CT angiography is the call. So here we use a no zone approach. So this is what is very important. No zone approach is used for stable neck injuries, and when we go for CT angiography, you will assess whether or no there is any injury. If there is no injury, students, you can go for observation, and if there is injury, the next call is CT guided angioembolization. If it fails, you will have a call for surgery. This is what is very important. So I hope the first image is clear to all of us. Let us go to the next image. So what is the management for this? Urgent neck exploration is the call for this patient. Next is, what are you seeing in front of you? You are seeing a dilated bowel where we have some twisting at the level of pelvis. And what is the diagnosis, students? It is what is very important. You have a classical diagnosis of volvulus. This is what is very important. Now try to understand what kind of volvulus. The typical shape that you are seeing, a kidney bean, or you can say a coffee bean appearance, is seen. So this is a sigmoid colonic volvulus. Sigmoid colonic volvulus. What are the important takes in this image? Let us understand, because this is very important for all of us to understand a volvulus on X-rays. Now let us discuss this. This is what is very important. Whenever we talk about the volvulus, what are the important things that we need to understand? Volvulus is nothing but a twisting of, you can say, mesentery on the, or you can say the rotation of bowel on the axis of mesentery. Now there are 2-3 important things that I am going to discuss. I shall not be discussing the complete volvulus, but I will be showing you how to see colonic volvulus on X-ray. So when we talk about colonic volvulus on X-ray, what are the important things that we need to understand? So we have 2 standard volvulus, but I will discuss the third one also. So colonic volvulus, there are 3 volvulus. You must have heard about cecal volvulus, you must have heard about sigmoid volvulus. Today I will teach you the transverse colonic volvulus. In the Dadagiri series one, where recently I have completed the intestinal obstruction, I have actually taught about the transverse colonic volvulus also. Let us try to understand all these things. Students, when we first, I'll cover cecal volvulus versus sigmoid colon volvulus. Now most of you look at the classical signs, but I, or majority of the surgeons, will always look at the apex of the dilated loop. This is what is very important. So if you see a cecal volvulus, so this is how the cecal volvulus is. This is how the cecal volvulus is. The first thing that you will have to notice is where is the apex of the volvulus segment. So here if you see, the apex is in the left upper quadrant. This is what is very important. Now since this is a volvulus, there has to be air fluid level. So there is multiple air fluid level? No, there is a single air to fluid level. So one air to fluid shadow. This is what is very important. The third thing that you need to understand is the typical shape of this. This is a teardrop. This is a teardrop sign. This is a teardrop, or a comma, you can say comma shape. So these are the certain things that you will be looking at the cecal volvulus. Now what you have to look at the sigmoid volvulus. Now when you talk about the sigmoid volvulus, it is again very interesting to understand. What is that? Students, where is the apex? The apex is towards the what quadrant? The apex is towards the left upper quadrant or right upper quadrant? It is right upper quadrant. Now try to understand one very important thing about this. Do you know it is towards the right upper quadrant, but in the late phases, it might transit from the right upper quadrant to the mid to the left. So yes, in the late upper quadrant, in the late, you can say, stages of volvulus, where the distension is massive, it is not surprising that you get to see that on the left upper side also. What are the other things that you need to understand, students? This is what is very important. So you have the fluid level. This is the fluid. And what is this, students? What is this? This is the air fluid column. So in the cecal volvulus, you were having single air to fluid column. Yes or no? But here you are having the air column is same. The air column is single, but there are 2 fluid columns. So you will say one air to 2 fluid columns. Can you see the difference? 1 air to 2 fluid columns. Then if you see this air fluid level and if you see this air fluid level, and that is what is giving you the classical pair of scales appearance. So pair of scale appearance, 2 fluid to single air column, the apex towards the classical right upper quadrant. And what is this classical sign, students? What is this? This is a classical coffee bean sign. This is one thing. Another important thing that you all need to understand here is that we also get to see bent inner tube sign. What is the classical concept of bent inner tube sign? This is important. Bent inner tube. Understand that the inner surface of the tube is more acutely bent, and that is what is a bent inner tube sign. Now this is what is very important. Apart from that, if you see these volvulus, it is something like this. Yeah, this is how the things are. Yeah. So there are 3 classical lines. If you see, this is one line, if you see this is another line, and if you see this is another line. So 3 classical line intersecting at a point, and this is what is known as Freeman-Dahl sign. So 3 lines intersecting at a point, and this is what is known as Freeman-Dahl sign. So Freeman-Dahl sign, these are certain important things that we need to understand on X-ray. Now when we talk about, simply let us quickly discuss their management also. Their treatment is also very important. For cecal volvulus, do you know it is very important that you go for a surgical laparotomy. You can say you go for a laparotomy. So surgical intervention is of paramount importance. So cecal volvulus, the management is laparotomy. And when we talk about laparotomy, what is the next thing that you do? Remember, you check the cecum. So check cecal viability. So when we talk about the cecal and the cecal viability, what are the things that you need to understand? If the cecum is healthy or if the cecum is gangrenous. If the cecum is healthy, then you have 2 options. Either you can go for derotation plus cecopexy. So derotation plus cecopexy is one call. This is one important thing. Another one that you have is you can go for resection plus anastomosis. So resection and anastomosis, whenever we talk about resection and anastomosis, what is the resection that we do here, students? We do a right hemicolectomy, because many a time some part of the ascending colon is also supplied, some part is supplied by the ileocolic, and when you do the ligation of ileocolic for removing the cecum, the vascularity may be jeopardized. So right hemicolectomy is what we prefer for, and along with that with iliotransverse anastomosis. So right hemicolectomy with iliotransverse anastomosis is what we go for. Now the next is the cecum, where when we are looking at the cecum might be what, students? Gangrenous. This is what is very important. If the cecum is gangrenous, what is the next call, students? You have to go for a resection and along with that anastomosis. Now the same surgery that we are doing, right hemicolectomy, and along with that anastomosis. Now if there is a cecal perforation, now here there is a twist. So if there is a cecal perforation, we will go for resection and along with that diversion and ileostomy. So this is what is very important. So why diversion? Because it's a temporary. So diversion and ileostomy. And do you know, with mucus fistula, you will wait for 6 to 8 weeks to allow the patient to stabilize and recover, and then you will be going for the surgery. This is what is very simple. The next is, when we talk about the colonic volvulus, what is the management of colonic volvulus? We all need to understand that in patients of all the patients of colonic volvulus, we don't have to go for surgery, not all. So only the patients with acute obstruction, non-resolving, you can say cases, will go for surgery. So colonic volvulus, we need to check the status of the patient. What is the status of the patient? Patient could be stable versus unstable. If the patient is stable versus unstable, what is the difference of management? Let us see. If the patient is hemodynamically stable, the next thing is try endoscopic derotation. This is what is very important. So try endoscopic derotation. If the patient is unstable, what is the management? If the patient is unstable, then what is the management? Let us understand. Okay. When we talk about endoscopic derotation, how do we do this? With the colonoscope, or you can do or with the classical flattest tube. So we have a flattest tube, we have a colonoscope. The next is, if the patient is having, if the patient fails to resolve with this, you will have to go for resection, and along with that anastomosis. So when we talk about resection, what is the resection we do? We do a distal sigmoidectomy, basically distal sigmoidectomy with the colorectal anastomosis. This is what is simple. When we talk about the unstable patients, yes, you will have to go for surgery. So resection, and along with that I will be opting for diversion colostomy. Now when we talk about diversion colostomy, it is of two types. Either it is a end colostomy with mucus fistula, or end colostomy with a Hartmann's pouch. So end colostomy with the Hartmann's is one option, and end colostomy with the mucus fistula is another option. So if you have the stump length sufficient, you will be going for end colostomy with the mucus fistula. If the stump is small, rectal stump is small, you will always be going for what? A closure of the pouch, and then after 6 weeks you shall be deciding. Now let us see this image. This is again a very simple image. What you are seeing in this image, you are having the radio tracer uptake in the different part of the body, and if you can say mark this silhouette, you can understand this is a area belonging to head and neck and thorax, which you can see. So a patient, let us have the history also. Long standing thyroid nodule with sudden toxicity. What do you mean by toxicity? Toxicity means the patient has the features of hyperthyroidism, and a thyroid scan was done. This is what is very important. So three important things that we need to understand. Do we actually do the thyroid scan for patients nowadays? No, not at all. At least for hyperthyroidism, we are not exposing the patient to radioactive, you can say, tracers. Why? Because when we expose the body, we sensitize the body to the radioactive agents, resulting in the future increased risk of salivary gland cancers and various other cancers. So when do we do the radioactive scan or thyroid scan for, you can say, hyperthyroidism? The answer is, we will go for thyroid scan only if there is doubtful diagnosis, and the second is, our plan of action is not a total thyroidectomy. If my plan of action is total thyroidectomy, why will I go for a scan? I'll confirm it on biopsy, what it was. So the indication is very limited in case of, you can say, hyperthyroidism. Anyways, let us see the case scenarios. So whenever we talk about the thyroid scan, what are the important things that we need to understand? So thyroid scan, case 1. For a normal thyroid, so whenever we do a thyroid scan for a normal thyroid, what is the classical appearance that we shall be getting? So this is a thyroid gland, and do you know the thyroid scan is having a typical, you can say, mindset that functionally active, you can say, gland that will actually accept the scan, and that will appear as what? And functionally inactive part of the gland will be appearing what? Cold. So inactive portion of the gland will be what, students? Cold. Now this is what we utilize. So whenever we give the technetium 99 or iodine 123, which is better? Of course technetium 99. Why it is better? Because of a shorter half-life, 6 hours versus 12 to 13 hours. The second very important thing is that the technetium doesn't get organified. But iodine, since it's a iodine, so it gets organified and it results in you can say, radioactive thyroglobulin combining with this and resulting in radioactive T3 and T4. Anyways, leave it. Try to understand one very important thing. So this is a normal gland. So when we talk about a normal gland, everywhere the uptake will be there. All the cells, all the follicular cells will have some uptake. And now this is what is known as a starry sky appearance. So what is a starry sky appearance pattern? The starry sky appearance is seen in patients with normal gland. So this is absolutely normal. There is no consolidation of the, you can say, contrast. Then let us talk about the case 2. When we talk about the case 2, let us understand a patient with hyperthyroidism, and in this patient there are no nodules and you gave technetium 99 or maybe iodine 123, and what did you get on the scan? You got something like this. Can you see the entire gland is hot, and this is what is known as diffusely hot gland. The complete gland is hot. So what does this mean? The gland is increasing in size. So goiter, it is hot. That means that it's a diffuse toxic goiter or Graves' disease, and this is what is very, very, very simple. So this is the concept of diffuse toxic goiter, or you can say the classical Graves' disease. The case scenario number 3. So when we talk about the case scenario number 3, what is that? So we have a gland with multiple nodules. So multinodular goiter with hyperthyroidism. So if you go for a thyroid scan in this patient, what shall you expect? So you gave iodine 123 or maybe technetium 99 and you got to see something like this. What is that? You got to see multiple hot nodules on what background? On cold background. So what is this basically? Multiple hot nodules on cold background. Students, you are dealing with toxic MNG, or this is also known as a plumber's disease. So a plumber's disease or a toxic MNG. This is what is the case scenario number 3. The case scenario number 4, let us understand. We have a gland, we have a nodule, and now the patient is having hyperthyroidism. So solitary nodule with hyperthyroidism. Now whenever we have a case of solitary thyroid nodule with hyperthyroidism, we want to understand whether this gland is hyperfunctioning or the nodule is hyperfunctioning. In that case scenario, it is what is very important for us to justify this, and therefore the moment you give technetium or iodine and you got to see this, so what are you getting this? A solitary what nodule, students? A solitary hot nodule on a what background? On a cold background, and this is what is the diagnosis of toxic adenoma. So we have a diagnosis of toxic adenoma, case 1, case 2, case 3, case 4. We have seen all these characteristics. So if you see this case scenario, what is the diagnosis that you have now? You have the diagnosis of toxic adenoma, and this is what is very, 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 very important. Do you know what is the association of toxic adenoma? Toxic adenoma is associated with GSP mutation. What is GSP mutation? There is a protein which is known as G-coupled protein, and there is a protein which is going to stimulate this G-coupled protein. So GSP stands for G-coupled protein, stimulatory protein. This is a gain of function mutation which causes a dormant nodule to hyperfunction, and this is what is very, very, very important. It is seen that this is associated with long-standing nodules with an average size of more than 3 centimeter. And what is the treatment for them? The standard management, the treatment of choice for them is hemithyroidectomy. This is what is very important. Now you must be saying, sir, why not we can go for radioactive iodine ablation? Yes, you can go, but the quantity of radiation required to ablate a nodule is far more than the conventional dose that can be tolerated by the gland. So do you know there will be a collateral damage to the normal healthy gland also, and therefore there's a high risk of radiation induced thyroiditis. So young patients, non-pregnant, young patients, pregnant patients planning to conceive, you cannot give. Yes, middle-aged female with nodule size of 2 centimeter to 3 centimeter, yes, you may attempt to go for radiation. So alternate management, alternate treatment we can have is radioactive iodine 131 ablation, or students PEG injection. What do you mean by PEG injection, students? Polyethylene glycol injection. Polyethylene glycol. This is what is very, 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 very important. So let us go to the next image that we have. Identification, okay, identify the principle shown. This is the principle that we have of the, you can say, wound suturing principles. The gap between the two sutures, ipsilateral, contralateral, we shall be discussing that. What is the ideal suture is to wound length? This is what is a bread and butter for all of us students. It's very easy also to understand. The ideal wound is to suture length is 1 is to, or you can say suture is to wound length, if you talk about, is 6 is to 1. This is what is very important. So if the wound, example, if I say if the wound is 10 centimeter, to close this you require a suture of what, students? Suture length of 60 centimeter. Now here I have shown the principle of ipsilateral suture distance and contralateral suture distance. So what should be the ideal gap between two sutures, between two suture bites? This is what is very important. So two suture bites ipsilateral and two suture bite contralateral. Before you understand what is the suture bite, you should know that these bites, they are ipsilateral and these bites, they are the contralateral. So A and B are ipsilateral and B and C, they are what, students? Contralateral. So the gap between the two contralateral bites and two ipsilateral bites, that is considered nowadays as 2x. What is 2x? Where x is defined as the thickness of the skin. This is what is very important, thickness of the skin. So if I talk about, okay, I want to do the suturing. So if the thickness of the abdominal wall is 2 centimeter, the gap between the two sutures should be 4 centimeter. If it is 1 centimeter thick, so the two contralateral, the two ipsilateral bites, so I have taken one bite and I have tied it. So this is one. Now the another one, the gap between them shall be what, students? It should be 2 centimeter. Why? The abdominal thickness is 1. Now what is ipsilateral bites? This is ipsilateral. What is the contralateral? This is. So remember, from the midline, it should be equivalent to the thickness. So if you see the gap between the two, it should be again 2x, where x is the thickness. It's a very easy question. Let us move forward and let us go to the next question. Comment on the lesion below. So you can see a typical ulcer located over the gaiter zone above the medial malleolus. So I have given a hint that yes, I am asking SEEP. So this is a question that is associated with what, students? With the chronic venous insufficiency. So let us discuss on the concept of chronic venous insufficiency. It is what is very important for us. So when we talk about SEEP, what are the important things that we need to understand in SEEP? SEEP is a grading system for, it's a grading system for chronic venous insufficiency. Now when we talk about chronic venous insufficiency, what are the important things that we need to understand? C stands for clinical, E stands for etiology, A stands for anatomy, and P stands for pathophysiology. So this is what is very simple. Now when we talk about the C, we have C1, which includes what, students? Spider veins or telangiectasias. So spider veins or telangiectasias and reticular veins. Now what is the difference between reticular veins and spider veins? 1 to 3 mm diameter veins are reticular, less than 1 mm, yes, subdermal or intradermal veins are known as the spider veins. We have C2, which qualifies for what, students? Varicose veins. So what is again the difference in diameter? More than 3 mm, broad, tortuous, cosmetically unacceptable. Now here there is a catch. If the patient is not having any symptom, that is known as C2A, asymptomatic. If the patient is having any complaint, any problem, that is symptomatic. What is C2R? If it has recovered, now there is a recurrence, so that is C2R. So A, S and R. Then what is C3? That is presence of edema. What is C4? All the skin related changes. So 4A is pigmentation. If you are following the American books like Schwartz, Sebastian, they are having 4A and 4B. What is 4B? Lipodermatosclerosis. So lipodermatosclerosis is what is 4B. Even they consider corona phlebiectasia or dermal flare also as 4B, but if you see the Love and Bailey edition. So they say that corona phlebitictia is 4C. What is the difference between corona phlebitictia and the lipodermatosclerosis? Entire zone of gator gets narrowed and bottleneck effect is generated. So narrow fibrous skin at that level, that is what is 4B. 4C is a patch of fibrosis with the, you can say, telangiectatic veins radiating or accreting out from that. This is what is dermal flare. Then we have C5, which is considered to be a what? Healed ulcer. Healed ulcer. We have C6, that is considered as non-healing ulcer. This is what is simple. Then we have, what about the etiology? So EC means by birth, EP means there is no associated cause and it is not associated from the birth, and ES means secondary. So suppose the patient had suffered an accident, an injury, or maybe DVT, and post DVT there is a swelling, so that is ES. So all the things which have a precedent history or cause or etiology, that is what is considered as ES. Then anatomy, when we talk about, AD means associated with the problem of the deep venous system, AS means associated with problem of superficial venous system, AP means associated with what? Perforator related problems. And then we have the P. What is P? Pathophysiology. So PO means it is associated with obstructive profile. PR means it is associated with what, students? Reflux. So obstructive, reflux, or it may be associated with both the conditions. So suppose if I give you a classical small question, if I give you a question, 42-year-old traffic police person. Yes, I will give you a small question. Presence with swelling over the left leg with dilated vein, recently he developed an ulcer above medial malleolus. On Doppler, echogenic debris noted in left posterior tibial artery with few incompetent below knee perforators. Now let us try to understand what is the SEEP for this. So this is what is very important. Patient presenting with swelling or edema. So there is edema here. So edema means what? C3. With dilated vein, something visible from the naked eye, that is C2. Recently developed an ulcer over the medial. So this is an active ulcer. So C6. There is no history. So etiology is considered to be what, students? Primary. Now echogenic debris noted. Where it is noted? Posterior tibial artery. So anatomy, if we talk about, it is the deep venous system. In a blood vessel, if there is debris, the flow will always have an obstruction. So pathophysiology is O. Incompetent perforators means there has to be regurgitation or reflux, and perforators are involved, since that is why anatomy is also including the P. So C, if we see 2 plus 3 plus 6, why? Varicose, edema and active ulcer. Etiology is primary. Anatomy is deep venous system because of the posterior tibial and the perforators. And when we talk about pathophysiology, obstruction due to debris and reflux due to the perforator. So this is the ideal correct way of representing the SEEP for this patient. So if we see, what is this? The answer for this, okay, it's an ulcer, so I can mark C6 because that's the highest value I can look here, because it's not a multiple correct. Had it been a multiple correct option, I would have also marked the C4 because the pigmentation is also there. So A and D both are right in this case. Next is identify the lesion shown in the endoscopy image of the kidney. So if you see this image, what are you able to see here? So this is looking we are looking at the, you can say, endoscopic view of a kidney, where we get to see discrete white patches. They are not something like concrete bodies, but white patches. And can you see, this is where they have deposited brown stains. They have taken a special brown stain. So what are these white patches on the renal epithelium? So white patches on renal endothelium or epithelium, whatever you say, endothelium we are seeing, and they are nothing but deposits of calcium hydroxyapatite. So they are nothing but calcium hydroxyapatite. And do you know, on the deposition over the renal endothelium, they will now start irritation. And since they will start irritation, all the organic and, you can say, non-organic substance shall deposit over this, resulting in formation of a well-defined stone. So I can say that they are nothing but the precursor of the stone, and since they are precursor of the stone, they have to be given a name of what, students? Randall's plaque. So what are you seeing in the image in front of you is Randall's plaque. This is what is very, very, very important. And what is this pattern of stone growth by deposition of one layer over the another? This is what is known as epitaxy. This is what is very, 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 very important. Epitaxis. What is epitaxis? This is nothing but growth of the stone. Growth of stone by deposition of one layer over another. This is what is very, very, very simple thing that we need to understand. So this is a classical image of renal concretions or calcium hydroxyapatite. The next is, we are seeing, if you see the image, we will see the image later. First, let us read the question. A newborn presenting with excessive drooling of the saliva. So one thing is clear, why the patient is not able to take the saliva in, definitely there is some problem with the esophagus. A newborn presenting with this, now this gives us a hint of what? The esophageal atresia. So first thing, now we are having in our mind that we could be dealing with a case of atresia. With choking on the feed, now this is more confirming and alarming. And now you have the image. Now if you see the image, this is trachea, this is esophagus, yes. If you see, this is the proximal end of the esophagus, yes or no? And then what is this, students? This is the distal end of the esophagus. So we have the proximal end, we have the distal end, and there is a gap between them. So therefore one thing is confirmed, that this is esophageal atresia. But wait, can you see the distal end is also fused with the what, students? The distal end is fused with the trachea. So since the distal end is fused with the trachea, so I would say that this is also a tracheoesophageal fistula. And what type? Distal tracheoesophageal fistula. Hence the diagnosis is, it is you can say esophageal atresia with the distal tracheoesophageal fistula, and therefore this is a type C type of defect. So let us try to understand the other questions. So identify the defect. I have told you that this is a case of esophageal atresia with a distal TEF. What are the lesions associated with this? What is the management? Let us quickly understand about this also. This is what is very, 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 very simple. So when we talk about esophageal atresia and TEF, try to understand they are associated with certain mutations which are NMYC, then we have SOX2, then we have CDH2, even we have CDX also, I don't know about that. So they are associated with vectorial group of defects. Now what do you mean by vectorial group of defects? V stands for you may have vertebral anomalies, this is one thing. A stands for you have anorectal malformations, this is one thing. So imperforate anus with or without fistula. Then we have C. What is C, students? C stands for cardiac anomalies. So we have cardiac anomalies like tetralogy of Fallot, we may have ASD, VSD. R stands for we may have renal dysgenesis, and L we have limb hypoplasia. So these are the classical defects which may be associated. So if you have a patient of anorectal malformation, always think that patient may be having concomitant changes associated with the esophagus, trachea, kidneys, the heart, vertebrae. So this is what is very important. Now when we talk about the types of esophageal atresia, this is what is very important. There are two broad types. What is that? We have pure atresia, this is one thing, and we have atresia with TEF. So let us try to understand them. So this is the esophagus, imagine this is the esophagus and this is the trachea. So this is trachea, this is esophagus, and if you see, this is what is known as type A, and this is the one which is pure atresia. This is what is very important, pure atresia. What are the another ones we have? So try to understand something like this. So this is a variety where you have the atresia. So atresia is there, but the proximal end of the esophagus is fused with the trachea. So this will be known as atresia with proximal TEF, This is what is the type B. Then we have the third variety, something like this, the variety which I have already shown. So atresia is there, and this is the variety of atresia with the what students? So atresia with distal TEF. So atresia with the proximal TEF we have, atresia with the distal TEF we have. So this is the type C. Then we have the type D. What is type D, students? The atresia is there, but the proximal connection is also there, the distal connections is also there. So this is a, you can say, type D. What is type D, students? We have atresia with combined, you can say, fistula. So proximal plus distal TEF, this is what is. And then we have no atresia. So just see, the esophagus is absolutely normal, but the problem is that they have a fistula with the what, students? Trachea. This is what is trachea, this is what is esophagus. So this is pure TEF, and this is the type E, or you can say the type H because of its shape. So we have type E and type F. We had Vogt classification, we have lot of different class. I'm not going into that, just understand the basic types. Type C is the most common according to incidence, then we have type A, then we have type E or maybe type H, then we have type B, and the least common is type D. So this is the most common and type D is the least common. This is what is very important. Without wasting the time, how will you approach this patient and how will you manage these patients? This is what is very important. So let me discuss this thing. So whenever we have a patient, a newborn, so a newborn with suspicion of esophageal atresia, this is what is very important. How do you have excessive drooling with choking of food and the violent cough on feeding? This is what is standard. So what is the next line investigation that you should be going for? So you should be going for X-ray. So what do? You put a catheter, and what is this catheter? You put a feeding tube, or you can say a feeding tube or a sump catheter X-ray. A feeding tube or a sump catheter X-ray. What is the significance of this sump catheter X-ray? This X-ray is having a, you can say, a line which is actually radio opaque, it's having a barium, so it can be delineating the structures according to the length. Now try to understand. So whenever we do the X-ray, this is the first line thing. On X-ray, do we see a blind pouch? So do we see a blind pouch in this? The answer could be no, the answer could be yes. So if you are seeing a blind pouch, students, one thing is confirmed, the diagnosis is esophageal atresia. One thing is there. So this is atresia. Now once you confirm that it is atresia, you need to understand whether it's a pure atresia or atresia of some with TEF. So the next is the gas in the stomach. This is what is very important. So is there any gas in the stomach? If the answer to this question is yes, it is only possible in case of what, students? Distal type of TEF, and that is the reason you say that this is esophageal atresia with TEF. Students, X-ray has its own limitation, so you cannot detect each and everything, but at least it is fairly sensitive. So gas in the stomach, if it is yes, then yes, it's a esophageal atresia with a TEF. Now try to understand. If you had a blind pouch, you said it's an atresia. Blind pouch with gas, it's a what type? It's an atresia with TEF. No gas in the stomach, so yes, let us consider to be a pure atresia. Now this is what is very important. A baby with a neonate with a suspicion of atresia, you went for a some catheter based X-ray and no blind pouch. Now what are you thinking of? So this baby might be having a type E or a type H. What is type E or type H, students? This is what is very important. In this patient, you will not have excessive drooling, but you will always have a violent choking or regurgitation or cough after feed. Why? Because of the connection. So this is a pure TEF, not a pure atresia. This is what is the limitation of what, students? The limitation of X-ray. Now why is X-ray very important? Because many of time you bluntly mug up a chapter or bluntly mug up a, you can say, topic and say ki, okay sir, I'll go for a contrast esophagogram. No, don't dare to go for. If you think it's a TEF, first rule out TEF and block the connection. Otherwise, the contrast will go and worsen the scenario, causing complex chemical pleuritis. This is what is very, very, very important. So now what to? So once you have a suspicion of TEF, so there is TEF, then investigation of choice is a flexible bronchoscopy, and this is what is very, very, very important. Now why do you go for flexible bronchoscopy? There are two things that you need to understand, because not only it is diagnostic, but also it may be temporarily therapeutic. How it is temporarily therapeutic? Yes, you can do the occlusion of TEF. And how you can do occlusion? We have two things. Either you can do a silicon plug occlusion, or you can do a balloon catheter base occlusion. These are two important things that you need to understand. Otherwise, contrast esophagogram will be havoc. So for esophageal, for pure esophageal atresia, the investigation of choice is contrast esophagogram. This is what is very, very, very important. Let us move forward. Based on the patient's clinical status, we have two criteria. We have a Spitz criteria and we have a Waterston criteria. Students, nowadays we are not using Waterston, we are using a Spitz criteria, which is very, very, very important. So when we talk about the management depends upon how sturdy the baby is. Can baby survive a surgery? This is what is very, very, very important. So try to understand something here. What is that? You need to see the birth weight. The birth weight is very important. Point number one. We need to check presence or absence of cardiac anomalies. So if the birth weight is present and cardiac anomalies, if the birth weight is okay, the cardiac anomalies are not there, what will be the management? If it is present, what will be the management? So let us understand birth weight, cardiac anomalies, the chances or the mortality rate, and therefore what is the management? Let us understand. If the birth weight is more than 2.5 kg and there are no cardiac, you can say, anomalies, the mortality, or you can say the chances of survival, I will say the prognosis, the prognosis or the recovery rate, it is more than 97%, and therefore definite surgery is the call for this. If the birth weight is less than 2.5 kg and no cardiac anomalies are there, still 55% recovery risk is there. So recovery chances are there. So you will go for surgery, definite surgery. This is what is very important. If the birth weight is less than 2.5 kg with cardiac anomalies present, less than 27% recovery rate, and therefore you will first make the patient sustainable, and therefore feeding gastrostomy should be done for these patients. And do you know, students, this is what is a modified Spitz criteria. So this is modified Spitz criteria and very, very, very important for all. What is the management? Definite management, you know. Yes, we will be going for excision and closure of the fistula with esophagostomy. This is what is very, 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 very important. So next is, let us see a patient, a 26-year-old patient presenting to you or 26-year-old smoker presenting with the following things. So you can see there is a gangrenous appearance of the foot, and if you see, this gangrene is also patchy. So it is infected here, it is infected here, it is infected here, maybe I don't know where else. So what is this? What is this? The most probable diagnosis. This is a case of classical case of Burgess disease. So what is a classical concept of Burgess disease? Burgess disease is a vasculitis, and this is a vasculitis causing peripheral arterial disease related symptoms, and this is mostly due to the smoking. This is what is very important. So when we talk about the diagnosis of Burgess, this is important. What is concept of Burgess disease? What is the concept of Burgess disease? It is a vasculitis of small, or you can say medium size vessels and nerves. This is what is very important. So vessels, and along with that it's a vasculitis infecting the nerves also. Remember, it is very important that smoking causes endothelial injury. Endothelial injury causes platelet aggregation and hence thrombus formation. And do you know, this is what is very important, because smoking will cause a variable, you can say, damage at different places. So at different places you develop atherosclerotic plaques or the thrombus, and these lesions, therefore they are known as skip lesions. So you don't have a uniformity of the lesion, you have the lesion affected at multiple places, and that is why there is no definitive cure like a bypass in case of Burgess disease associated with associated peripheral arterial symptoms. Remember, normally if you have chronic atherosclerosis, you can do a bypass, but not in these patients because of the presence of what? Skip lesions. So what is a diagnostic criteria? It's not possible to teach everything, but still, what is a diagnostic criteria for a patient of Burgess disease? Let us understand. So we have two criteria. We have a Shia-Noyes criteria, we have a criteria by name of Ollins. So Shia-Noyes criteria, we have a Shia-Noyes criteria, or we have a Ollins criteria. I'll just discuss some important features. Age of the patient should be less than 45 to 50 years. So young patients. Along with that, they should be smokers. So smoking. Along with that, they should be associated with no diabetes mellitus or atherosclerosis. So no diabetes or atherosclerosis should be there. Students, superficial thrombophlebitis might be there. So superficial, you know, that is the classical signs that we see in Burgess, and some you can say some malignancies of the GI tract also. So superficial thrombophlebitis might be there or no. Presence or absence of skip lesions. And do you know, distal lower extremities involved first. So distal lower extremities, they are involved commonly, and this is what is a classical Shia-Noyes or Ollins criteria. When we talk about their management, stop smoking, ecosprin and cilostazol, which might increase certain vascularity and improve the patient's symptom. But in the long race, this is a progressive disease, and you will have to advise that sooner or later you'll need an amputation, because vascular bypass is not going to work. Now there's a concept like, okay, let us go for a lumbar sympathectomy. Lumbar sympathectomy is actually a placebo in these. Why it's a placebo? Lumbar sympathectomy is a time buying process. Whenever you do lumbar sympathectomy, you actually cause a local peripheral vasodilatation, so blood flow improves, the healing of the wound occurs, and that is why you prepare this limb now for the bypass. But in case of Burgess, there is a skip metastasis, there is a skip lesions involved, and thus you will not get anything. Yes, extensive collateralization is there. That is why if you do you can say CT angio, you'll get to see an inverted tree appearance, or you can say a spider leg appearance. All those things are there, but because of the skip lesions, we have a limitations of management. So this is about this classical image of Burgess that we see. Next is, following is a cut section from a kidney demonstrating a tumor. So where can you see the tumor? If you see this kidney, here is the tumor. So this is a place where you can see a tumor. So this is basically a tan or mahogany colored tumor. So tan or mahogany, you can say, colored tumor. So what are the differential diagnosis for this? Sir, I have one diagnosis as it could be a clear cell. It could be a clear cell RCC. The second is that I think that it could be chromophobe RCC. And the third is that it could be oncocytoma. Anything can be there. So this is the classical differential diagnosis. Amongst them, the oncocytoma is a benign entity, clear cell and chromophobe is malignancy. But if you see lot of clear, you can say cytoplasm is there. Now this is again favorable. This is again favorable for clear cell as well as chromophobe. You know, we get to see plant cells, plant cell. Then we have resin nuclei or nucleus. Yes, lot of eosinophilic staining. But the hallmark is this blue stain. There is only one tumor in RCC category which has affinity for the iron based stain, and this is what is Hale colloidal iron stain. So any tumor of RCC category which is positive on Hale colloidal iron stain, students, that is only and only one tumor, that is chromophobe. So what is this? This is a chromophobe RCC. This is what is very important. So chromophobe RCC is the answer here. Next question is based on the staging, management and follow-up. RCC is important for each and every exam, for each and every medical student. So let us understand the basic nutshell based management strategy for RCC also. Let us quickly understand that. So whenever we talk about the RCC and its staging system, the older staging system, that was Robson, is an obsolete. We have adopted the WHO 2014 modification of that, and now we post 2014 we are using this Robson's only, staging. So according to this, we have T1, which is further divided into T1A and T1B. T1A is more than less than equal to 4 centimeter tumor. T1B is more than 4 centimeter up to 7 centimeter. This is T1. Then we have T2, which is more than 7 centimeters up to 10 centimeters, that is T2A, and more than 10 centimeters, that is T2B. What is the significance of this T1A, T1B? Everyone knows that whenever we want to do a partial versus radical, this is the benchmark. But what about the concept of T2A and T2B? Do you know laparoscopic nephrectomy can be done only up to 10 centimeters? So the answer is lap nephrectomy. Lap nephrectomy can be done up to T2A, not beyond T2B. So T2A, basically not beyond T2A, you cannot go for. Then we have T3. What is T3? We have again T3A. What is T3A? Into perirenal fat. So into the renal fat. Along with that, into the renal sinus. What is renal sinus? It is a confluence of collecting duct with the vascular system. This is what is very important. Then what is T3B? What is T3B? This is again very important. Into IVC. When we talk about IVC, we have a level of the liver. So below the liver IVC, above the liver IVC. So below the liver, or you can say diaphragm. So below the liver or diaphragm, that is T3B. T3C is into IVC, extending beyond. So above the level of liver or diaphragm. This is what is the T3. When we talk about T4, what is that T4? It is into the ipsilateral zerotas fascia. This is one thing. So ipsilateral zerotas fascia or ipsilateral, we have what, students? The adrenal glands. So this is what is important. Next is when we talk about the N, either there is no regional lymph nodes, or students N1 is positive regional or para-aortic, what, students? Lymph nodes. This is what is very easy. Now the most important thing is the management. I shall take some time for this and I shall discuss this because this is what is very important. When we talk about the treatment part of the RCC, you have to understand the gold standard of the management is nephrectomy. This is what is very important. When we talk about the nephrectomy, we have two types of nephrectomies. We have partial nephrectomy and we have the radical nephrectomy. So the first is who belongs to what category. So what is the indication for partial nephrectomy? Answer is T1A tumors. T1A means less than equal to 4 centimeters. What is the indication for, you can say, the radical nephrectomy? Answer is T1B onwards. But do you know this is not a whole soul criteria? If a patient is having a solitary kidney for even tumors more than 4, you will be going for what, students? Partial. The third is contralateral disease kidney. What do you mean by contralateral disease kidney? It is just equivalent to a solitary kidney. The fourth criteria is a patient with pre-existing CKD. Do you know this is very, very, very important? When we talk about CKD, once we remove one kidney, the entire load of renal filtration is on one kidney. So this overloaded kidney is obviously going to develop CKD in the future. When you have a pre-existing CKD and you remove one kidney, you are hastening the process of death. Remember, the concept of oncosurgery is any surgery done with an intention to prolong the life expectancy. If you cannot prolong the life expectancy, then you don't have to do that surgery. This is the basic rule of the, you can say, oncosurgery. Do you know, apart from this criteria of the size, we have a score which is known as renal score. So what is this renal score? You can say renal score or renal criteria is a criteria for deciding the partial nephrectomy versus radical nephrectomy. When we talk about the renal, R stands for the radius of the tumor. So you know, less than 4 centimeter, more than 4 centimeter, this is one. Then E stands for, it is exophytic. That means a tumor is extending outside the kidney, or endophytic. So exophytic or endophytic. Then we talk about N. N is nearness to collecting duct. So nearness to collecting duct means more incidence of the vascular base, you can say, extension. Then we have A. A stands for anterior or posterior. So anteroposterior extension. This is what is very, very, very important, because the width of the kidney in the anteroposterior dimension is not very high. It's a 3, 6, 9 or 3, 6, 10 base configuration. So anteroposterior diameter or extension. And then we have L, location with respect to poles. Location with respect to poles. So when we talk about location with respect to poles, a polar location is more favorable. So very, very important. Parts removed. Now when we are talking about the parts removed, in partial nephrectomy, you can remove as much kidney you want. This is what is very important. In partial nephrectomy, you can remove as much kidney you want, but the leftover portion should be functional, and this is what is making it very, 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 very important. So at least that is spare at least 20% functional kidney. So you can remove as much you want, but you have to spare 20% functional kidney. When you talk about the other one, what is that? The radical nephrectomy. So what are the parts removed? Yes, you have to remove the kidney, and along with the kidney, the abdominal part of the ureter, along with that, the perinephric fat, along with that, what else you have to remove? You have to remove the regional lymph nodes. And will you remove the zerotas? Yes, you will remove the zerotas, fascia. Will you remove the adrenal, plus minus adrenal? So when will you remove the adrenal? This is again a very important question. So adrenal is removed if involved, either it is involved or you know, if it is upper pole tumor. So if it is a upper pole tumor, then you will remove adrenal, or if the adrenal is involved, then you will remove. So these are two important things that you need to understand in this case. Then remember, what are the complications? So post-surgery complications. When we talk about post-surgery complications, it is very, very, very simple. Remember, when we talk about the radical, the contralateral CKD will happen. When we talk about this one, you will always develop excessive loss of proteins to the kidney, because you have reduced the size of the kidney. So proteinuria will result in chronic hypoalbuminemia, and this is because of the loss of ultrafiltration function of the kidney, and that is what is known as UFS. What is UFS? This is ultrafiltration syndrome. So this is the concept of ultrafiltration syndrome. So this is what is done. Next is, and we are left with the follow-up of the kidney or follow-up after RCC. Do you know the RCCs are radio resistant, so we don't go for the radiotherapy. So post-surgery, this is what is very important. So post-surgery, you have to take them for chemotherapy. There is no role of radiotherapy because of the classical, that they are radio resistant. I'll not discuss chemotherapy here because it will be very lengthy. So we have sunitinib, sorafenib base, imatinib base, pazopatinib. Then we have, there are certain, you can say sirolimus, that is mTOR receptor inhibitors. So leave them. Let us talk about the follow-up. Now this is what is very important. So follow-up, there are two types of follow-ups. For low risk group, and for high risk group. So what is high risk group, students? It is T2 and above, or any T with N positives. This is what is low risk group? T1, N0, M0. These patients are low risk. So first thing is, once the surgery is done, you will have to repeat a baseline CT or MRI. Yes, and this is done for both the category after 3 months. After that, what you have to do? You have to do for low risk annual CT or MRI up to 3 years. This is what is simple. Whenever the patient will come, you will also go for chest X-ray. Why? The metastasis to the lungs are the most common distant mets. So same follow-up. When we talk about the T2 and above category, that is the high risk, you will go for 6 monthly CT and MRI for 3 years, and after that annual CT or MRI up to 5 years. So we say up to 5 years. Why? Because two consecutive negative scans after 3 years. So we have already done 5-year follow-up. So we stop that. So either 5-year or up to 5 years, or up to 2 negative scans. This is what we do. And chest X-ray, whenever you go for CT MRI, you follow the same protocol. So this was about this question. Next is, a newborn presents with recurrent emesis and failure to thrive. This is what is again a simple question. A newborn presents with recurrent emesis and failure to thrive. One thing is clear, that the source of recurrent emesis with failure to thrive means, why failure to thrive? The food is not going inside. Why emesis? Because there is a blockage. So one thing is clear, that we are dealing with atrachas. This is not the barium image, but this is the barium image only. So the barium follow through, upper GI barium follow through has been done. And can you see the barium here? So this is the stomach. I can understand this is the stomach which is over distended. And this is the pylorus. Now why is the second part of the first part of the duodenum so much distended, and after that there is a very feeble amount of barium which has gone inside? So this is a classical double bubble sign. This is a classical double bubble sign on the barium, and this is diagnostic of one very important thing, that is the duodenal atrasia. This is what is very important. This is important. So duodenal atrasia, what are the causes, what are the types, what is the management? Let us understand. So with this question, we have just been able to diagnose it very smoothly. Let us understand the pattern of duodenal atrasia here, and this is what is very important. So whenever we talk about the concept of duodenal atrasia, what are the important things that we need to understand? Let us see this. Students, atrasias are very common. Duodenal atrasia is not that common. The most common atrasia of the GI tract is the jejunal-ileal atrasia, which is very frequent. But duodenal atrasia is the most frequent cause of obstruction. Let us understand the associations when we talk about. What are the classical associations? We have it associated with biliary atresia. So one thing is it is associated with biliary atresia. The next is annular pancreas. It may be associated. Understand about the types. The types may be, the first is the atresia is there, but there is not complete atresia. So there is a present below is carrying the web distally and giving you a typical conical presentation. This is what is. This is a type 1 where we have only webs. What is type 2? Type 2 is a atresia where complete atresia happens, but the mesenteric separation is not there, and this is what is very important. The mesentery is intact, and this is what type 2. When we talk about type 3, this is complete atresia with separation. So type 2 is different. Their separation is not there. Here the complete atresia with separation or a V-shaped defect. So if you see here, this is how the things are. So the mesentery is also separated. The mesenteric defect is also there. This is what is a type 3 atresia. Do you know, when we talk about the management, this is important that we go for end to side, we can go for side to side, or we can go for a diamond shape or diamond orientation. Diamond orientation, you can say duodenostomy, duodenostomy. This is also known as Kimura surgery. Let us understand what is the concept of this diamond anastomosis. Students, there is a disparity. Lot of times there is a disparity in the lumen size, and that is why the most feasible is, let us place the bowel in this orientation. So end to side or side to side. End to side is the least preferred. This is the most popular. This is the most popular. This is the second most popular, side to side. What are we doing in the diamond shape? So we are keeping both the lumens like this. So if I am talking about this, I'll keep this lumen like this. And when I keep this lumen like this, what is the orientation of the anastomosis? Just see. The widest aperture with least risk of post-surgery obstructions. This is what is very important. You have to be alert in case of the annular pancreas, that you don't divide the pancreas. This is important. Do you know what kind of vomiting is associated with duodenal atresias? It is bilious or non-bilious? It is bilious vomiting. Why? Majority of the atresias happen distal to the ampulla, and this is what is again a very important thing. Let us move forward. Let us move forward and go to the next question. Now, following is the barium meal. Following is the barium meal image of a patient with intermittent chest pain, dysphagia and regurgitation. Now, if you see, what are you seeing? What is the diagnosis? So this is the classical esophagus. The barium is going into the esophagus. This is the place where the G junction is there. So can you see, this is the G junction. Yeah. And then the barium has gone into the stomach. Pylorus has crossed, the duodenum the barium has reached the duodenum. But one thing that you can see, that barium has also gone into the mediastinum, out of the way. And this is not out of the way. This is because of the part of stomach protruding into the mediastinum. And the diagnosis, this is what is the diagnosis of PEH. What is PEH, students? Paraesophageal hernias. So this is what is very important, that this is a classical case of paraesophageal hernia. Now, when we talk about the paraesophageal hernias, what should we be looking at? What are the different types and what is the management? Let us try to understand each and everything in this topic of paraesophageal hernia, PEH. Whenever we talk about PEH or paraesophageal hernia, this is also known as hiatus hernia. Let us quickly discuss what are the types of hiatus hernia. When we talk about the types of hiatus hernia, we have type 1, which is known as sliding hernia. What is a sliding hernia? Where the GE junction goes up into the mediastinum. So this is what is the type 1, where the GE junction moves up. Students, this is the most common type, but this is not a true PEH. So this doesn't qualify for true PEH. This is one very simple thing. What is the another thing that we need to understand in the case of sliding hernia? Since the G junction moves up, therefore they are classically associated with what, students? Reflux. This is important. Then we have the type 2. What is type 2, students? Type 2 is a condition where we have an intact G junction, but the fundus or parts of stomach along with the fundus have gone up. So G junction is right at its place, but the fundus plus others, plus minus others, yes, other part of the stomach, only of the stomach, they have gone up, and this is what is type 2. And this type is known as rolling hernia, and rolling hernia, this is associated with obstructive features. Students, then we have the type 3. When we talk about the type 3 hernia, what are the important things that we need to understand in type 3 hernia? The G junction has gone, the stomach with fundus or other parts have gone, and this is what is type 3. So type 3 is a mixed type, and it's a mix of rolling plus what, students? Sliding. The G junction has gone up, along with that the fundus or the others, you can say plus others, that is belonging to stomach, have gone up. Students, try to understand, this is the variety which is associated with what? Which is associated with reflux, plus minus it is also associated with what, students? Obstruction. This is what is important. Do you know that it is the type 3 which is associated with organoaxial volvulus of the stomach? So organoaxial volvulus of the stomach, this is a classical association of this type 3. Then we have the type 4. What is type 4? Now this is what is very important. In this type 4, there may be a possibility that the stomach has gone up or has not gone up, but along with the stomach or maybe isolated, some other organs have gone up. This is what is important. So this is paraesophageal hernia with stomach. Now this is a new update with stomach and other organs, with stomach and other, you can say, viscera protruding out, and this is what is a type 4 PEH. When we talk about the investigation of choice, it is nothing but barium esophagogram or barium study. But do you know, the irony is that sliding hernia might be missed. So before ruling out sliding hernia, so if you have a patient with a strong presentation of reflux and you think it's a sliding hernia, but barium is not telling, always understand that upper GI endoscopy with a retroflexion view is the standard of investigation, with angle of His being obtuse. There is no gastric flap. The configuration of the stomach present in the esophagus, this is what is diagnostic. So barium study, and along with that upper GI endoscopy with retroflexion view, this is what is mandatory for the diagnosis. Do you know CT scan, like Bailey Love also says, is not the standard of investigation for the diaphragmatic hernias which are not hiatus hernias, like congenital hernias. There the CT and MRI are useful, not in the case of hiatus hernia. This is what is important. And when we talk about the management, you know, reduction is one thing. So you do the reduction of content, point number 1. Along with that, you need to prevent the recurrence. And how do you prevent the recurrence? You need to understand, sir, I need to reinforce the hiatus. So how do you do the repair of the hiatus? So yes, we do repair of hiatus with the help of what, students? PTFE mesh. So Gore-Tex mesh repair is done. And what about the crural repair? So crural approximation is also done. So try to understand, if you only repair, so try to understand that this is the hiatus. So you have placed the mesh. I am happy that you have placed the mesh. The recurrence will not here. But what about the gap in the crus? Sliding hernia will happen. So therefore you need to bring the, you can say, bring the crush, right crush, left crush and repair them. And this is what is known as Ellison's repair, Ellison's repair. Now remember, whenever you are doing anything around the G junction, you always alter the, you can say, tone, and thus you need to understand, you will also have to go for prophylactic fundoplication. This is what is very important, and we do anterior door 180 degree fundoplication. When we are talking about this, what is door fundoplication? This is what is a door fundoplication 180 degree. This is what is very simple thing that we need to understand. So you've completed the management of this image also. Next is identify the pattern of knot shown in this image, and this is what is very easy for you people to understand. Knots I have already taught, but still there are a lot of students who are always confused between the knots. Let me tell you whether this is reef or granny. Try to understand whether this is reef or granny. You need to have a, you can say, simple concept. What is a reef knot? What is a granny knot? It is a two-throw knot. So can it be Melzer and Aberdeen? No, it's a two-throw knot, one throw and two throw. There are two throws. So one thing is clear, that it's a two-throw knot. Now how to identify the granny versus reef? It's a two-throw. So the rule is select any one end. Select any one end. This is what is very important. And once you select that end, then always look for symmetry. This is again very important. So look for the symmetry. If it is symmetrical, understand that you are dealing with a what? A classical reef knot. If this is asymmetrical, you are dealing with what, students? Granny's knot. Now how to see this concept here? Let us see. Let us label three ends, 1, 2, 3. So here we are having two threads, one is blue, one is orange. So try to understand, if you see this end, if you see this thread, above upper thread, below thread. So orange is below the blue. So orange is below the blue on the upper side also. On the lower side also, orange is what, students? Orange is below. So therefore on this side this is symmetrical, so I will say that this is a what knot, students? This is a reef knot. Let us take it on the other side. If you see on this side, orange is above, this is a symmetrical. Blue, if you see on this side, blue is above, so this is a symmetrical knot. I will show a very similar image of a knot, and that will help you understand granny versus reef. Just give me a minute, I will show you a classical knot, grannies versus reef. Okay, where is it? Where are you? Okay, yeah. Let us see this knot. Again apply the same rule. Select any one end and look for the symmetry. Try to understand. Select any one end and look for the symmetry. So I will select 1, 2 or 3. Let us select this end. If you see, the red is below. In this case, the red is below the blue. Yes or no? Can you see the red is below the blue? And on this side, the red is above the blue. So if you see, the red is above on this side and red was below on this side. So this is what? This is an asymmetrical knot configuration, and therefore this will be a what? A granny's knot. This is what is very important. Again try to understand. The red is above here. The blue is above here. So red is above, the blue is above. Again this is asymmetry. Again just see. The blue is above in this on this side, the blue is below on this side. Students, it's an asymmetrical configuration, and that is what is granny's knot. Granny's knot is a slip knot, and therefore when will you use reef? When the point of creation of the knot and point of execution of the knot is same, I will use a reef. I need to tie it here only, I will create and tie it here. That is a reef. If I want to create a knot and push it inside the abdomen to my location, I cannot secure it at the time of, you can say, creation. So I need to slip it to that point, and that is the reason why we create reef knot in the prior purpose. In this purpose, you have to create a what? Granny's knot, slip it to the site of, you can say, ligation, and then you have to secure. So this is what is reef versus granny. This is again very important. There is one more image on the knots. Let us understand that also. What is that? Let us see that. Okay. What is this? So whenever you have to do a continuous knotting, so you will do a loop out of loop. Recently I've uploaded the video of that also on Instagram or in my surgery you can say section also. So loop out of loop knotting. What is this loop out of loop knotting, students? This is known as Aberdeen's knot. Aberdeen's knot. What do you mean by Aberdeen's knot? You are taking a continuous knot. Now you want to ligate it. So you will create a loop and you will pull the tail inside and then you will secure it. So multiple loops that you take. I shall share you a video also that will help you understand a lot of things. Try to understand it via this video. Try to understand it via this video. So if you see, I am doing the loop out of loop knotting, loop out of you. Most of you do this when you are closing a vault or whenever you're closing the anastomotic, you can say side. So I have done lot of continuous. Now just see, I am pulling out the loop out of this loop. So pulling the proximal end after pulling the tail, that will secure and tighten it. Again I will pull the tail and tighten it on the proximal side and it is getting locked. Again I will do the same and this way this is getting secured. This is what is loop out of loop, and then I will do an Aberdeen termination. So this complete knot technique is known as Dundee jamming and Aberdeen termination. Dundee jamming, why it is known as Dundee jamming? The initial process of locking is Dundee jamming. This knot technique was designed in Scotland, where in Scotland Dundee is the northernmost tip. You start from the Dundee and you jam it and go to the southernmost tip, that is the Aberdeens, and that is why Dundee jamming and Aberdeen termination. So Dundee jamming and Aberdeen termination. Aberdeen termination. This is what is the complete name for this knot. This is what is very simple, very simple. Let us go to the next question. Let us resume our, you can say, journey to that. Okay. Okay. The next image. What are you seeing in this? You are seeing an image of pressure sores. So how do you define pressure sore? What is the grading of the pressure sore or the decubitus ulcer? Let us understand. First of all, the diagnosis is, this is a case of decubitus ulcer, or you can say the pressure sore. So pressure sore or decubitus ulcer. I don't know what is the problem with this. Okay, let us understand each and everything and then we'll come back to this. So whenever we talk about the pressure sore or decubitus ulcer, what are the important takes in this pressure sores versus and decubitus ulcer? In patients with chronic immobilization, there is loss of pad of fat. So the cushion is lost and therefore the external pressure is directly applied on the capillaries, and that is the reason there is necrosis and thus there is ulceration and damage. And this is what is very important. So this is pressure induced necrosis of the skin, subcutaneous tissue and the muscles, resulting in an ulcer. So when we talk about this is the P external, and P external will try to collapse the capillary. Do you know, to collapse a capillary we have a pressure which is known as COP. So what is COP? Basically this is capillary occlusion pressure. Normally the external pressure cannot reach the COP level. Why? Because of the pad of fat. So this is what is very important, and the normal COP is 30 to 32 mmHg. This is what is very important, 30 to 32 mmHg. Now let us understand what is happening. Whenever there is chronic immobilization, the P external is more than COP and therefore ischemia will happen, and ischemia will cause necrosis, and necrosis will cause what, students? Ulcer, and this is how the things worsen. Now students, try to understand, the most common site is not the sacrum, it is the ischium. So this is what is very important, ischium. Then we have the greater trochanter. This is what is again very important. So ischium, the greater trochanter. Then we have the sacrum, and then we have the heels, and then we have the malleolus. So all these things are in the chronology or sequence. Now when you talk about the grading, the grade 1 is nothing but blanching and redness. So blanching plus redness is what we get to see in grade 1. What is grade 2? It is partial thickness ulcer. So partial thickness ulcer is what is grade 2. What is grade 3, students? It is full thickness ulcer. What is grade 4, students? It is 3 with extension into the deeper structures. With extension into deeper structures. This is what is very, very, very important. Now when we talk about this image, what is this grade? You can see the entire, you can say, crater with the bone visible. The bone is visible. This is the bone that you are visualizing. The muscle is visible. So remember, it's a grade 4. Grade 4. When we talk about the management, it is very, very, very simple. The treatment is debridement. One thing is debridement of the necrotic content. Along with that, the vac closure. You can go for a vac closure plus minus, you can say, grafting post the healthy, you can say, granulation tissue has arrived. So vac plus this, and along with that you need to give a proper antibiotic, you can say, cover. Now when we talk about the prevention, this is again very, very, very important. So prevention is done in 2 ways. Prevention, first of all, the weight offloading is important. So weight offloading, how can you do the weight offloading? This is what is very important, is change of posture, regular change of posture. Now when we talk about change of posture, we get questions on this also. What is the concept of change of posture, students? Remember, every 2 to 3 hourly for bedridden patients. This is what is very important, and when you are sitting, the pressure is even more. So when you are sitting, it is every 10 to 12 minutes, every 10 to 12 minutes for 10 to 20 seconds. For what category patients? Chair ridden patients, and this is what is very, very, very important. For bedridden patients, we also have the air or water mattress. So air or water mattress is again very, 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 very important. So this is all about the session 1. In the session 2, we shall be resuming from here only. So I hope you are enjoying this high voltage image fest based revision. So till then, bye bye, bye bye. We'll resume again in the second session. So hi everyone, good afternoon everyone. Just starting with this session. Okay, hi. I hope audio and video is clear to everyone. Just a minute. Okay. So this was the last question that we did. So again, those who have joined new, so welcome to Surgery Dada, and this is a visual fest where I am trying to discuss as much as content possible. So so this was the last image that we discussed, and this was the image on the pressure source. So we've already done that. Next is let us see this question. A 42-year-old chronic smoker presents with white fibrotic patch over the lateral part of the tongue. So can you see this image? So what is the diagnosis just by looking at this image? So there are white flaky lesions over the tongue, and hence I would say that this is a classical leukoplakia. So this is a classical diagnosis of leukoplakia, and this is what is very, 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 very important. So when we talk about leukoplakia, with respect to this leukoplakia, what are the things that all except are true? Let us understand, and we shall be discussing a lot more about leukoplakia. It is associated with dyskeratosis. This is absolutely wrong. Why? Because leukoplakia is associated with parakeratosis. Yes, it is a pre-malignant lesion which is going to lead to SCC. Speckled variety is the most pre-malignant type of leukoplakia, and white excision or radiotherapy is what is going to be performed. So without wasting any time, let us continue with the same session. So in the same, I will just mention, so this is the session 2 that we are starting. So those who join and this PDF gets uploaded, so there should not have any confusion. So when we talk about the leukoplakia, what are the, or let me take a new PDF only. Okay, so this is a new, okay. So when we talk about the leukoplakia, what are the important things that we need to understand? So with respect to leukoplakia, this is a pre-malignant lesion of the oral cavity. And when we talk about the oral cancers or oral cavity, when we talk about what are the important things, what are the different pre-malignant lesions? So we have leukoplakia, erythroplakia, chronic submucosal fibrosis. What is leukoplakia? On histology, if you see the histopath, on histology, you get to see intense parakeratosis of the, yes, parakeratosis is seen in them. So pleomorphism with atypia, we don't have pleomorphism is seen, but the dysplastic changes are still to happen. When we talk about leukoplakia, it is nothing but a white fibrotic patch. So white patch over the tongue area, this is what is telling us about leukoplakia. What are the other important things that we need to understand? What are the types of leukoplakia? So when we talk about the types of leukoplakia, we have a nodular variety of leukoplakia, we have the diffuse type of leukoplakia, and the third variety is the speckled type of leukoplakia. So remember which leukoplakia amongst them is the most common. It is the nodular variety which is the most common type. It is the speckled type. What is speckled type? So there are multiple small clusters of, you can say, or multiple patches in a group, just like a herpes infection, it looks like that only. So that is what is speckled. So speckled leukoplakia is the most pre-malignant leukoplakia of all. So we have nodular, we have diffuse, we have speckled type. The second pre-malignant lesion that we have is erythroplakia. Do you know amongst them, erythroplakia is the most pre-malignant lesion. Remember students, remember one very important thing, that leukoplakia is the most common pre-malignant lesion, but erythroplakia is the most pre-malignant lesion. Why? If you get to know what do you see on histology, you will never ask me again. On histology, we get to see dyskeratosis, and this is what is making it 30 times more pre-malignant than the standard leukoplakia. The third is nothing but a chronic submucosal fibrosis. When we talk about chronic submucosal fibrosis, what are the important things that we need to understand in this? Whenever we expose ourselves to the chronic irritant, so whenever the oral cavity is exposed to chronic irritants, what is going to happen? Of course, this is going to lead to damage. And do you know, eventually all the damages will heal, and the healing happens with the what, students? Healing happens with the fibrosis. Now try to understand, since you are addicted to smoke, you are addicted to betel nut, you are addicted to ill-fitting dentures, so definitely this is going to cause a re-exposure to these chronic irritants, and again the same vicious cycle, and one fine day healing damage, whenever it goes and continues in the cycle, yes, it undergoes a dysplastic changes, and this is what is chronic submucosal fibrosis. Remember students, submucosal fibrosis is not a pre-malignant lesion, but chronic submucosal fibrosis is a pre-malignant lesion. That is why it is very, 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 very important. Do you know, I will just discuss 2-3 more important things about the oral cancers, because again oral cancers are very, very, very important topic for all. So oral cancers, whenever we talk about the most common type of oral cancer overall, and in West or in Asia, everywhere, it is the SCC. The most common site for the oral cancer in the West, it is the tongue, and in India, we are addicted to Kamla Pasan, Vimal, whatever you say, Gutka, Pan Masalas. So in Asia, and especially in India, it is the gingivo-buccal complex, or you can say the buccal cavity, and this is what is very, very, very important. Do you know, when we talk about the prognosis, the most important prognostic factor that we have, lot of us believe that it is the depth of invasion. No, it is not the depth of invasion. It is the lymphovascular invasion more than the depth of invasion. This is what is very, very, very important. So lymphovascular invasion more than the depth of invasion. What else is important when we talk about the prognosis? The best prognosis, who is associated with best prognosis? The answer is cancer of the hard palate is associated with the best prognosis. And when you talk about the worst prognosis, next time you go for a movie and see Mukesh Harare, you know, the typical emblem, or you can say brand ambassador of the oral cancer prevention campaign that is going on. So he tells about that he has sold his wife's and bangles and this and that and blah for the surgery. So what is that cancer? That's again the buccal cavity. So buccal cavity is the most common cancer also, and is the cancer with the worst prognosis also. So CA buccal cavity, this is what is important. Now when we talk about the approach to this, we need three things: planning for the investigation, decide the stage, and treat. So quickly I will discuss with you the concept of this. Now whenever we talk about the staging of the oral cancers, we will discuss staging. And what is the investigation of choice? Investigation of choice for the staging we have is PET-CT. PET-CT. Remember both the cavities and both the extremes of the GIT. So oral cavity and the anal cavity, the PET-CT. For the diagnosis or histological confirmation, answer is the biopsy. So you can go for the classical true cut, incision, excision, whatever you say, punch biopsy, wedge biopsy, you can go for that. When we talk about the staging, we have the AJCC, 8th version of staging for the oral cancers. And what is that? Let us understand. T1 is defined as tumor size less than equal to what? 2 centimeter. Or depth of invasion. So depth of invasion is very important, less than equal to 5 mm. What is T2 students? More than 2 up to 4 centimeter tumor size, or depth of invasion more than 5 up to what centimeter students? 10 centimeters. What is T3? More than 4 centimeter, or remember depth of invasion more, I've written centimeters, it should be mm, sorry. So more than 10 mm, this is what is very important. And then when we talk about T4, what is the T4 students? You can say any size with local invasion. So when we talk about local invasion into the muscles of mastication is T4B, and what is T4A? Into the floor of mouth, into the mandible, all these things come into the T4A. And what is T4B? Into the muscles of mastication. This is what is very, very, very simple. But what is more interesting and confusing is the N. So lymph nodal staging is very important. So what is N1? It is a solitary or a single lymph node. So solitary lymph node, but the size criteria is very important, less than 3 centimeter. What is N2 students? It is further divided into N2A. What is N2A? It is a solitary lymph node more than 3, but none of them should be more than 6 centimeter. What is N2B? Answer is multiple lymph nodes, but none of them should be more than what? 6 centimeter. We have N2C, that is bilateral lymph nodes, but none of them should be more than equal to 6 centimeter. Then we have N3, that is any lymph node more than 6 centimeter. You say unilateral, you say bilateral, anything. Important is, next is the concept of extranodal extension. When we talk about extranodal extension, less than 3 centimeter with extranodal extension, this is considered to be N2. More than 3 centimeter with extranodal extension, this is considered to be N3. So this is what is the T and M. Let us quickly discuss the management protocol for the oral cancers. When we talk about the management, we need to understand management of pre-malignant lesion, management of the oral cancer. So let us see. So if it is carcinoma, if it is pre-malignant lesion. When we talk about pre-malignant lesion, the next is we go for wide local excision with 0.5 centimeter margin. No need for further management. What are the alternates? We can go for radiotherapy also. We can go for laser excision also. Many a times you can go for laser excision also, or we can also go for topical 5-fluorouracil. This is what we can do for the pre-malignant lesions also. When we talk about the cancers, what is the management for cancer? This is again very simple. Wide local excision with 1 to 2 centimeter margin. Remember, the safe margin for the oral cancer is considered to be 1 centimeter. It should be more than 1 centimeter. Along with that, we have to go for SOHND. What is SOHND, students? Supraomohyoid neck dissection. Where are you going to remove? You are going to remove the level 1, level 2, level 3. Remember one special case, and that is the cancer of the tongue. Just like thyroid cancer, upper pole cancers have a tendency to go as a skip metastasis by a direct route of invasion into the lateral part of the neck. Similarly, the cancer of the tongue has a tendency of skip metastasis to level 4. So important that you need to understand, for cancer of the tongue, we don't go for SOHND. We go for extended SOHND. What is extended SOHND? Level 1, 2, 3, and also we will be removing level 4. This is what is very important. And after that, yes, you have to follow these patients plus minus chemotherapy plus minus radiotherapy. This is what is. So radiotherapy 60 grays over 6 weeks. Do all the patients require radiotherapy? Let us understand. So what are the indications for radiotherapy? This is what is very simple. Remember, T3 and onwards, this is one thing, T3 and onwards. The second very important thing is depth of invasion more than 4 mm, more than equal to 4 mm. Then the next very simple and important thing is that N2 and above. So not for N1, N2 and above. This is again important. And then whenever the tumor free margin is found to be less than what, students? 1 centimeter. So these are all indications, and in case of what? Relapse. So these are the indications for radiotherapy. Let us continue with our series. And okay, so you know why this keratosis was the answer. Next is answer the following with respect to this limb. Just by looking at this limb, you will say that this is a case of elephantiasis or it is a case of filariasis. Just give me a minute. Just give me a minute. Okay, so what are we looking at? We are looking at lymphedema. So let us quickly discuss. The diagnosis that we have is lymphedema. So lymphedema, I am writing L-edema. So this is lymphedema and resulting in lymphedema. The next very important thing is that what are the features? How did you diagnose this? So can you see the classical features? Tree trunk limb. So the first thing that you have to see is tree trunk looking like limb. What are the other important features? You can see loss of malleolar pitting. So loss of malleolar pitting, this is one more thing, very important. Do you know the skin above the, you can say the skin above the extremity is so much stretched that normally I can pinch the skin, I cannot pinch the skin here, and that is why inability to pinch the skin. This is what is known as Stemmer's sign. So what is a Stemmer's sign? Inability to pinch the skin. This is what is Stemmer's sign. What else is important, students? This is a classical buffalo hump. So buffalo hump, you get to see a buffalo hump, and this is what is very important. So buffalo hump. What else is important? If you see the toes, what are these toes, students? These are the classical square toes. The classical square toes. So squaring of the toes, buffalo hump. You might also get to see certain skin changes, which is known as lichenification of the skin. So these are the classical cardinal changes that help us diagnose that this is a case of lymph edema resulting in lymphedema. So what are the various things that we need to understand? Let us quickly give 5 minutes to this, or not 5, 4 minutes rapid fire discussion on lymphedema. So whenever we talk about the lymphedema, we need to understand that it is of how many types? 2 types, primary versus secondary, and all this depends upon the cause. So if the cause is unknown, then that is primary, and if the cause is known, then that is secondary. Do you know, when we talk about the cause, the most common may be filariasis, it is the most common cause. What are the others? We may have it due to trauma, we may have it due to radiotherapy, we may have it due to post surgery. Remember, the most common surgery that we have is MRM. This is again very common, very common. It may be due to infection. When you don't know the cause, then the timing of, or you can say the time of onset is very important. So whenever you have primary, the age of onset is very important. So less than equal to 2 years, up to 2 years, this is what is known as congenital lymphedema. Congenital lymphedema. This is also known as Milroy's disease. Milroy's disease. This is again very simple. Remember, more than 2 years up to 35 years. What is this known as? More than 2 years up to 35 years. This is known as lymphedema praecox. Remember, lymphedema praecox is also known as Meke's disease. Meke's disease. This is again very important. More than 35 years, this is known as lymphedema tarda. So there are 3 important things that we need to understand. When we talk about evaluation for them, I've already told you the clinical features. Understand that history is the most important. History is the most important in deciding the diagnosis. This is what is important. The second very important thing is that investigation of choice for lymphatic obstruction. This is what is very important to confirm whether it's a lymphatic obstruction or no. That is what is known as lymphoscintigraphy. So lymphoscintigraphy is the investigation of choice for the classical confirmation. Remember, what do you do in lymphoscintigraphy? Standard is, we inject the dye in the first web space and we wait for the lymphatics to collect this and take it to the regional lymph nodes. Remember, whenever you inject the dye, the lymphos urine is what is the standard dye that we use, technetium 99 sulfur or sulfurs urine, lymphos urine, whatever you say. We use this dye, we check the uptake after what, students? 30 minutes. So after 30 minutes, I will check the uptake at the level of regional lymph nodes. So for extremities, I'll check the axilla. For lower extremities, I'll check the inguinal lymph nodes. Now what to do? Normal uptake is 0.6 to 1.6%. So normal uptake after 30 minutes is 0.6 to 1.6. Remember, uptake less than 0.3. This is indicative of lymphatic obstruction. Remember, sometimes there is a lymphedema, you are not able to diagnose, and you did this lymphoscintigraphy and you saw that uptake is more than 3%. This is indicative of what? Venous obstruction. And remember, uptake more than 10% is possible only when you have neovascularization, and that is why this is indicative of what? Malignancy. So in all the cases of cancer or malignancy, you will have this. This is what is very important. When you talk about the treatment of lymphatic edema, the first line is medical. And remember, it is, if it fails, yes, which will fail, the treatment of choice is always surgical. But do you know, the surgical treatment is also theoretical. So in surgical, we have a bypass grafting, which is not the standard of the care. Do you know why? Because it is not possible to anastomose the lymphatics with the vessels. But what is preferred is the cosmetic palliative treatment, and that is LRS. What is LRS? Limb reduction surgery. What do you mean by limb reduction surgery? I've already taught. Go to my section of lymphatic edema and you will get to know. The aim of this limb reduction surgery is to palliate the extra fat, and that is what is the cardinal thing that we have. So extra fat, you are going to remove all the extra fat, and thus the girth of the limb gets reduced. What are the different limb addiction surgeries that we have? You know, one is cyst trunk. You must have heard of cyst trunk surgery in thyroid also for thyroglossal duct cyst. The another one is Charles, that's a 360 degree. If you are still not able to recall, go to my lectures and check it. We have the Thompsons. Where you go for excision of the skin. No, you don't excise the skin, you excise the extra tissue. Tuck the extra skin like shirt and pant appearance. The fourth is Conto-Lyons or Homens surgery. So these are the classical 4 surgeries. Without wasting time, I'll move forward. in the standard venous bypass surgeries, we have the Nellibo-Wick surgeries, the Kinmoth surgeries. I'll not discuss it right now. Next is identify the surgery shown in the image. So this is what is very, very, very important, very simple. What are you seeing in this image? Let us see. This is liver. This is liver. This is the IVC. This is the renal vein. What is this? This is the portal vein. Now try to understand. This is the splenic vein. Now splenic vein, you are diverting it. So what is this surgery all about? This is basically shunting. You are going to shunt the vessels, and this is DSRS, distal splenorenal shunt. This is what is DSRS. So for all the extra hepatic portal vein obstruction, you do this distal splenorenal shunt. Let us, by this you can say image, let us discuss about the classical concepts of the shunt. Let us understand. So whenever we talk about portal shunts, what are the important types of portal shunts we have? So I'll take 5 minutes of yours and cover each and everything. Whenever we talk about the portal shunts, they fall into 2 broad categories. For portal hypertension patients who are not the candidate for transplant, who are responding to tips, etc., we will go for the shunts. And these are the patients where actually the MELD index is also less than 15, so not favorable for the transplants. Let us understand. Portal shunts are of 2 types. What are the 2 types? We have veno-venous shunt, that means vein to vein. So veno-venous shunt. And the another type we have is peritoneovenous shunt. So peritoneovenous shunt, what do we mean by this peritoneovenous shunt? That means that we are going to shunt the ascitic fluid into the, you can say, into the internal jugular vein. This is what is the very, very, very simple. So when we talk about the peritoneovenous shunt, that means from the peritoneal cavity, you are connecting this with the, you can say, with the venous system, and basically the left internal jugular vein is the classical, you can say, target for this. So when we talk about the peritoneovenous shunt, the first we have is Lee-Veen shunt. What do you mean by Lee-Veen shunt? It is nothing but peritoneal cavity to internal jugular vein. This is what is. But don't you think that there should be some regulatory device deployed so that only the shunt fluid goes, not the debris goes, and then there should be someone to check the, you can say, pressure of the content flowing into the internal jugular vein, and that is why we have the Denver shunt. So what is a Denver shunt? Denver shunt is a peritoneovenous shunt. So peritoneal cavity to internal jugular vein, and there is a device implanted onto the anterior part of the chest wall. And what is this device? It controls 2 things. It controls the flow rate pressure, one thing. It also controls the debris entering into the, you can say, into the system. This is what is very, 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 very important. So we have a Denver shunt, we have a Lee-Veen shunt. These are 2 important things. Now when we talk about the veno-venous shunt, what are the things that we need to understand? That means vein to vein. So here also we have 2 broad categories of shunt. What are the 2 broad categories of shunt? Student, the first is non-selective shunt and the another one is selective shunt. So let us talk about what is non-selective shunt and what is selective shunt. Students, the problem here is the portal hypertension. So if we are diverting the entire portal flow into the vena, into the IVC or the system, that is what is known as non-selective. And what do you mean by selective? We have selected a vessel and based on that we are. So for all the extra hepatic portal vein obstructions, we have the selective shunts. When we talk about selective shunts, we have distal splenorenal shunt. So when we talk about distal splenorenal shunt, what are the important things about this? Students, this is the splenic vein into the left renal vein. This is what is very important. So splenic vein into the left renal vein, this is what is distal splenorenal shunt. Important thing that you need to understand is it is the shunt of choice for extra hepatic portal vein obstruction in infancy. This is what is very important. This is also known as Dean-Warren shunt. So Dean-Warren shunt is another name for the same distal splenorenal shunt. It is what is very simple. The another one we have is Inoguchi shunt. What is Inoguchi shunt? This is nothing but coronary caval shunt. What is coronary caval shunt? Are you going to connect the heart with this? No. Coronary caval shunt means you are going to connect left gastric vein, which is also known as coronary vein, with the IVC. So this is selective vein. So for gastric varices, isolated gastric varices, we might go for this. Remember, non-selective shunts are only for the what category patients? For the traditional extra hepatic portal vein obstructions. Let us talk about the selective, non-selective. I'm talking about, I said selective venous shunts are for the extra hepatic. Now let us talk about non-selective. Now non-selective shunts, when we talk about, we have certain shunts like porta-caval shunt. What is portocaval shunt or porta-caval shunt? It is nothing but portal vein into the IVC. This is what is porta-caval shunt. Another one is we have mesocaval shunt. What is mesocaval shunt? Students, the inferior mesenteric, the superior mesenteric vein into the IVC. This is also. The third is PSRS. You must have seen DSRS. This is PSRS, which is the proximal splenorenal shunt. The same proximal splenorenal shunt, that was known as Dean-Warren shunt, and this is known as Linton's shunt. So this is what is very important. When we talk about the porta-caval shunt, now this is what is important. Let us understand. So porta-caval shunt, what is important about porta-caval shunt? Let us understand. Porta-caval shunt is again of two types. What is that? We have end to side porta-caval shunt, and we have side to side porta-caval shunt. When we talk about end to side, what does that mean? Just try to understand. This was the portal vein. You ligated the lower end of portal vein and you diverted this end into the what, students? Into the IVC. This is what is known as end to side, and this is also known as X fistula. Always remember, X fistula was the first portal systemic shunt or you can say portal shunt, or any you can say portohepatic shunt performed. And remember this E, it is reserved for the emergency. It is the shunt of emergency. So whenever we have to do anything for emergency control of the bleeding, so this is for emergency. Why it is not as a standard procedure? Because okay, now you have diverted the portal blood into the IVC. It's okay, you have diverted the portal vein into IVC, diverted the portal hypertension, but still the hepatic artery is entering, and hepatic artery is bringing the blood, which is further not relieving the congestion completely, and thus ascites is not relieved completely with this. And this is what is very important. When we talk about side to side, what is the concept of side to side? So this is the portal vein which is entering, this is the IVC which is going side. We bring a graft, basically left internal jugular vein can be used, or a synthetic graft can be used, and we can do the anastomosis. So can you see, this is a side to side shunt. This is the ideal shunt for veno-occlusive disease, or you can say ideal shunt for Budd-Chiari syndrome. So for Budd-Chiari syndrome, or you can say veno-occlusive disease, we use this shunt. Why? Because not only this blood, but the hepatic artery related blood will have a retrograde flow and will again flow into the IVC, and that is why both the portal system, the hepatic congestion is relieved. Now, based on this shunt, or you can say based on this shunt diameter, this is of two types. So portosystemic shunt, non-selective type, veno-venous shunt, non-selective type, side to side portavenous shunt is of two types. What are the two types? It may be complete or it may be partial. So what is complete and what is partial? This all depends upon the shunt diameter used. If the shunt diameter that you are using is less than 8 to 10 mm, then that is a partial. If it is more than 10 to 12 mm, then that is considered to be what? Complete. And this is what is really very important. So we have end to side, we have side to side portosystemic shunt. So this is all about the shunts that you need. Let us move forward. And the next image is this. So can anyone answer, what are you seeing in front of you? What is this image telling you about? Upper GI endoscopy, and this is the classical image that you see. I hope you can just guess this thing by looking at the next slide. So I hope you know that, okay, you can see esophagitis. Esophagitis is there. Along with that esophagitis, what else can you see here? Students, you can see the classical goblet cells. And what are these goblet cells telling you about? Can you see these goblet cells? Yes, this is the Barrett's esophagus. Yes, you are thinking right. The diagnosis here is a Barrett's esophagus, and this is what is very important. So patient has the reflux, dysphagia. You know what is Barrett's esophagus, why it is associated with reflux. You should know that Barrett's is defined as the end stage GERD, and that is why it is very important. So what is the diagnosis? The diagnosis is the Barrett's esophagus. What is the alternate diagnosis? Esophagitis. Esophagitis. It can be erosive esophagitis. It can be eosinophilic esophagitis. Lot of types are there. How do you confirm? How did we confirm the diagnosis? The diagnosis was confirmed with the help of histopathology. On HP, you get to see columnar metaplasia. What is Barrett's esophagus? It is defined as any length of columnar lined esophagus. Remember, any length. Normally it is squamous. Any length of columnar epithelium lined esophagus with the metaplasia, with intestinal metaplasia. So intestinal metaplasia is there with the goblet cells on histopath. So goblet cells are the one which make it actually the Barrett's esophagus confirmation. Next is, let us talk about the management of Barrett's. This is again very important. So when we talk about the Barrett's esophagus, we all need to understand 5 important points on Barrett's esophagus. What are they? The first is, Barrett's esophagus is nothing but end stage GERD. And when you talk about end stage GERD, therefore there is increased risk of adeno-CA. Point number 1. What is Barrett's esophagus? Normally when we see the esophagus, the epithelium of the esophagus is squamous and the columnar epithelium is just 1 to 2 centimeter above the G junction. And this line that we have, this is what is known as Z line, or you can say in a 3 dimension, you can say ora serrata. So on the endoscopy, upward migration. So there is upward migration of the, you can say, of the standard Z line. And when you do a biopsy, you take a biopsy, you will find this. This is what is important. So what is a short segment, or what is a short Barrett's esophagus? Less than 2 centimeter, or you can say less than 3 centimeter is short. What is ultra short Barrett's esophagus? When we talk about ultra short, less than 1 centimeter. What is long segment Barrett's esophagus? The long segment Barrett's esophagus is more than 3 centimeters. So these are 3 important things that you need to understand. What are the types of Barrett's esophagus, and based on that we are going to do the management also for them. Students, when we talk about Barrett's esophagus, the confirmation, so investigation of choice for them is biopsy. Now biopsy is done via special protocol. And what is that protocol? That is what is a Seattle's protocol. What is a Seattle's protocol? So suppose if you have a patch of Barrett's, you will take the random biopsy at every 1 to 2 centimeter every 1 to 2 centimeter until and unless you get a what, students? Until and unless you get a normal epithelium on the biopsy. So this is also sometimes known as mapping biopsy protocol. Every 1 to 2 centimeter in all quadrants you are going to take the, you can say, biopsy. One more thing before I discuss about the types. What is the classification? So we have a classification which is known as a Prax classification, or you can say this is also known as the CM classification or C and M classification. When we talk about C and M classification, this is an endoscopic classification of Barrett's. So whenever you see the esophagus, and imagine this is how you are looking at the Barrett's, this is how you are looking at the Barrett's. Okay, so this is the place where you have the Barrett's. Now if you see up till this level, there is circumferential Barrett's. So there is circumferential Barrett's at this length, and this is what is known as the C. So from the G junction you will measure, and this is the C distance. Then if you see the proximal most tip, this is the maximum length of the Barrett's column. This is the maximum length, and that is why this is known as M. So example, if I say circumferential length is 3 centimeter and maximum length, if I say, suppose example I am giving you is 5 centimeter. So we will say Barrett's is C3M5. This is how you write Barrett's esophagus. The next very important thing about the Barrett's esophagus is, let us talk about the types, and based on the types I will discuss here the management also. This is what is very important. When we are talking about the types and the management, the first thing that we need to understand is Barrett's esophagus without dysplasia or without atypia. The second one is Barrett's esophagus unknown for atypia. So unknown for atypia. In either of them you are going to do only one thing. What is that? You are going to go for the PPIs. So you are going to go for PPIs or anti-reflux therapy. So we have the anti-reflux therapy or PPIs, and you are going to go for annual endoscopy follow-up. Annual endoscopic follow-up. Remember, unless two negative scan. This is what is important. Let us try to understand one more thing. Then we have LGD. What is LGD, students? We have low grade dysplasia. When we talk about low grade dysplasia, what are the important things that we need to understand? And one is high grade dysplasia. For low grade dysplasia, same. Anti-reflux therapy, this is one thing. We are going to go for anti-reflux therapy, and along with that, instead of annual, we are going to go for 6 monthly endoscopic follow-up. This is what is again very important. Then the next is high grade dysplasia. What is the management for high grade dysplasia? Let us try to understand. Whenever we have high grade dysplasia, you have to go for 3 monthly anti-reflux therapy. Once you do this 3 monthly anti-reflux, you have to do repeat upper GI endoscopy, and if the diagnosis still persists to be high grade dysplasia, you have to plan intervention. When we talk about intervention, what is the intervention? Either you can go for endoscopic mucosal resection or endoscopic submucosal dissection, or you can go for radio frequency ablation. And here we have a technique which is known as Halo 360 degree, or you can use Halo 90 degree. So when we have Halo 360 degree, or we have one more, that is Strata. I'll show one image also to you, and that will actually clear what is Halo 260, Halo 360. And okay, this is what is a Halo device. This is a circumferential 360 degree burning, and this is 90 degree. So for the segmental Barrett's 90, Halo 90 is good. This is Halo 90, and for the circumferential length, you can say if there is circumferential, we can go for Halo 360. Based upon what is the requirement, we will be going for that typical type of, you can say, usage. Let us move forward and let us go to the next question. Let us see. So next question we have this. What can you see a young female presenting with recurrent abdominal pain? What can you see? Just give me the diagnosis, just give me a minute. Okay, let us move forward. There was a patient with acute pancreatitis, gallstone pancreatitis. Okay, I hope audio is clear now. Audio is clear. Okay, so what can you see in this? Let us try to understand. Young female with recurrent upper abdominal pain. I hope I have just switched on the audio. Yeah. Okay, so young female with recurrent upper abdominal pain with intermittent jaundice. This is a classical triad, intermittent jaundice with such an ERCP profile. So let us see this. What are you seeing, students? Let us try to understand. This is pancreas. So this is pancreas. This is, it's okay. So this is pancreas, this is liver, this is gallbladder, this is the cystic duct confluence, this is the bile duct. Now understand, this is the duodenum. This is the duodenum. Now when you talk about the duodenum, try to understand that this is the confluence between the pancreatic duct. So this is the confluence between the CBD and the main pancreatic duct. Don't you think this confluence is happening outside the gallbladder? And that is why this is diagnostic of abnormal biliopancreatic junction. So this is what is ABPJ shown in this image. This is what is very important. Abnormal biliopancreatic. So what it will lead to? ABPJ will lead to choledochal cyst, and this is very important. So let us quickly revise the concept of ABPJ and how we see choledochal cyst, the types of choledochal cyst, and with this I will cover one more question on choledochal cyst also. So let us try to understand each and everything. When we talk about the ABPJ, or let us understand when we talk about the choledochal cyst, what is the classical presentation of a choledochal cyst? Answer is, it is right upper quadrant mass, right upper quadrant pain, and along with that you don't have weight loss, but you have intermittent jaundice also, and you have intermittent classically acute pancreatitis. So this acute pancreatitis, the logic is it is self-resolving, and intermittent is also, that is the reason why we say it is self-resolving, and in a young female. Remember what is the classical DD for this? If we talk about the hepatocellular cancer, what is important here? So hepatocellular cancer has a typical profile of right upper quadrant mass, right upper quadrant pain, and along with that you have what, students? Significant weight loss in a middle-aged male. This is what is very important, and this is diagnostic of HCC. Now students, try to understand. I don't know why this marker is getting deviated. Okay, let us try to understand why this happens and what is the concept of this. Let us understand. So whenever we talk about the concept of ABPJ or concept of choledochal cyst, this is associated with ABPJ. What is ABPJ? When we talk about the confluence of the CBD with the confluence of the MPD, it is always the intraduodenal confluence. This is the normal confluence. And when we talk about the ABPJ, the confluence of the CBD is outside the duodenum, when we talk about confluence of CBD with the confluence of the MPD. This is what is ABPJ, and because of this ABPJ, what is the problem? Therefore, there is reflux of active pancreatic juice, out of the acinus of the pancreas. The juice is activated from trypsinogen to trypsin, and this is actually a very, you can say, protein erosive, protein dissolving enzyme. So reflux of pancreatic juice into the CBD, and because of this lot of things happens. There is erosion of CBD. The moment there is erosion of CBD, there will be thinning of the CBD. The moment there is thinning of the CBD, what will happen? There will be dilatation, and this is the reason for what, students? Choledochal cyst. This is one thing. Remember, whenever there is erosion of CBD, what happens? There is formation of the protein plaques. Why this protein plaques form? Because of the damaged insipiciated wall of the CBD, and these protein plaques, they are going to cause blockage of the CBD with the main pancreatic duct. And do you know, sooner or later there is dissolution or there is washout of this plug. Do you know, the moment, suppose, imagine this is the scenario. So there is a protein plug, coagulated protein plug. This is dissolved. This is causing obstruction to CBD bile flow or pancreatic juice flow. So pancreatic juice can dissolve it, and bile can throw it or wash out it, and therefore you have intermittent self-resolving what, students? Jaundice also, obstructive jaundice also, and the another one is acute pancreatitis. This is what is very important. When we talk about the types, so we have the classical Alonso and Todani classification. So when we talk about Alonso and Todani classification of this biliary, you can say choledochal cyst, what are the types? We have total 5 types of, you can say, choledochal cyst. So what are the types? The type 1, this is in fact the most common type. It is the cyst along the common bile duct. Now when we talk about the cyst along the common bile duct, we have 1A, which is considered to be cystic. We have 1B, which is considered to be fusiform, and 1C, which is considered to be what? Saccular. So what is saccular? This is something like this. This is a saccular type. What is fusiform? 360 degree. This is what is fusiform. What is type 2? Now try to understand, this is what is the trick. What is type 2? It is a saccular cyst. It is a saccular cyst along the supraduodenal CBD. Now you will say, sir, supraduodenal CBD, what does that mean? CBD is CBD, and saccular cyst along the CBD, you have said 1C. So what is the difference between 1C versus type 2? Answer is their origin. The origin of type 1 is ABPJ, and the origin of type 2 is non-ABPJ. Is that clear or no? So both of them are same, but if it is associated with the ABPJ, it will be considered as 1C, not the type 2. This is what is very important. Then we have type 3. This is also known as choledococele. When we talk about choledococele, what does that mean? It means that it is the cyst along intraduodenal CBD. So cyst along the intraduodenal CBD, this is what is known as choledococele. When we talk about choledococele, what are the important things? So this is something like this. The CBD itself is actually distended at the terminal portion of the ampulla, and why this is giving you a cystic presentation, this is known as a choledococele. Next is, when we talk about the type 4, what is type 4? This is also ABPJ associated. So type 3 is non-ABPJ, type 2 is non-ABPJ, but type 3 is ABPJ associated. We have 4A and we have 4B. So what is 4A? It is multiple intrapleural plus extrahepatic cyst. It is multiple intra plus extrahepatic cyst. This is 4A. What do you mean by 4B? It is multiple extrahepatic cyst. Extrahepatic cyst. This is what is. And when we talk about type 5, this is what is known as the Caroli's disease. This is again a pre-malignant condition. Do you know this is solitary or maybe multiple intrahepatic cyst? Why they are quite different? Do you know they are associated with intense periportal fibrosis, and therefore there is increased risk of cirrhosis. Why? Because of intense periportal fibrosis, and therefore they have increased risk of what? Malignancy, and thus we consider them as pre-malignant. On USG, on CT, on MRCP or MRI, you get to see a typical central dot sign. And what is the central dot sign? This is the fibrotic spot that we have in them. This is what is very important. When we talk about their management, investigation of choice is MRCP. Remember, the treatment of choice is excision and followed by the Roux-en-Y hepatico-jejunostomy. If you talk about the Caroli's, what is the management for Caroli's? This is important. If it is resectable, then you will have to go for hepatectomy. If it is non-resectable, then in that case you will have to go for liver transplant. This is what is very important. When we talk about the type 2, what is that? Type 2 is a saccular, so we don't require you can say HJ. So excision with primary closure over the T tube. This is what is very simple. If you further need to understand, go to my evening lectures where already I have taught the choledochal cyst. Do revise it from there, because in the main Dadagiri series I have started with GIT. I have not completed, but in the evening series I have just done it. So you can go there and check this out. When we talk about type 3, you will go for endoscopic de-roofing of the cyst, because you know it is the intraduodenal CBD where the cyst is. So just de-roof the cyst. If it fails, then we have to go for transduodenal opening of the. So where do we open? This is again a question. So transduodenal excision with sphincteroplasty. You have to repair the sphincter. This is what is very important. So there's a common question: how do we repair? Where do we repair? At the junction of, when you talk about the C, upper two-third and lower one-third. This is how you open. This is you open 2 to 3 centimeter longitudinal incision is given. But how do we go for the closure? This is again very important. So do you know we always have to widen the defect, otherwise there will be scarring. So if this is the scenario, you will vertically extend it, and now you will go for a purse string based closure. So you will do a purse string closure of half. This is what, and you will also close this. So if I try to close this, the first bite that I will have to take is, I will take a central bite and I will divide this rent like this, and then I will do a purse string based closure of this also, and purse string based closure of this. This is how we close this rent of transduodenal sphincteroplasty. So with this I have done one more question. Let me show that question. Where is that question? This is a question on choledochal cyst only. Where is that? Okay, this is. I've completed everything. Comment on the diagnosis. Let us see this. Comment on the diagnosis of this. So this is the gallbladder and this is the supraduodenal. So this is a saccular cyst. So what is the diagnosis? So this is a saccular supraduodenal cyst, and this is type 2 or type 1C. We don't know. Since the biliopancreatic junction is absolutely, you can say in this case it is lying bit out, but still it is the intraduodenal. I would say 2 is better answer than 1C. This is what is very important. So 1, 2 is, I've told you the presentation, management, everything we have discussed it right now. Let us discuss one more question. Go to the previous diagnosis only. Okay, then we have the easy ones also. Okay, where we were. Okay, yeah. Okay. So now we have this question. What is this? This is a classical bird beak appearance. So 35-year-old patient presenting to you. Let me just remove. Okay. 35-year-old female patient presenting with dysphagia, chest pain, regurgitation. Following is the barium image, and what do you see on this image? Let us understand. I see the smooth tapering. I see the smooth tapering of this, and this is what is known as the bird beak appearance, and this is basically diagnostic of achalasia. Now comment on the pathology, comment on how the things happen, the workup, everything let us discuss here. So whenever we talk about achalasia, it is a part of motility disorder. I will not teach complete motility disorder, I will just teach you what is happening in achalasia. So when we talk about achalasia, the achalasia word means failure to dilate. So what is that policy of esophagus? Let us understand. Do you know esophagus has two types of, you can say, neurons? Intrinsic, when we talk about intrinsic neural pathway, we have two types of intrinsic neural pathway. Intrinsic neural pathway. We have excitatory ganglions and we have inhibitory ganglions. So we have inhibitory ganglions and we have excitatory ganglions. Now when we talk about excitatory ganglions, they will secrete acetylcholine, and they are going to, inhibitory ganglions, they are going to secrete NOS, nitrous oxide synthetase, and also they are controlled by the Meissner's corpuscles, or the Meissner's, you can say, plexus, and the myenteric plexus. So we have Meissner's plexus and we have myenteric plexus. Remember, the inhibitory ganglion side, they are responsible for relaxation of the esophagus, and the excitatory ganglions are responsible for the contraction of the, you can say, esophagus. Now do you know what happens in achalasia? In achalasia you have slow but progressive loss of the inhibitory ganglions, and this is what is very important, and therefore there is uncontrolled action of acetylcholine. So when there is uncontrolled action of acetylcholine, what is going to happen? The first thing is the maximum changes start with the distal part of the esophagus. So the tone of the LES will increase, and that is why this LES becomes hypertensive. This is what is the first thing that happens, and along with that, this fails to relax. So there is failure to relax and there is hypertensive LES. This is what you see on manometry in case of LES. Next is, when you talk about the peristalsis, peristalsis is a synchrony between the inhibitory and excitatory ganglions, and therefore there is aperistalsis. Why there is aperistalsis? Because there is no inhibitory support now. So aperistalsis, this is one thing that you see. Even the peristaltic waves which are generated to some extent by the proximal part, they are all low amplitude waves. So what are you getting to see? You are going to see low amplitude waves. Do you know, on manometry we have a concept of IRP, intermittent relaxation pressure. So IRP in this case is always less than, intermittent relaxation pressure is less than 15 mmHg. This is what is very important. So on manometry you get to see lot of things. IRP less than 15 mmHg. The distal contractile integral. What is distal contractile integral? DCI. It is nothing but peristaltic vigor. This is what is defined as peristaltic vigor. What is this peristaltic vigor? This is defined as the duration of contraction. So duration of contraction multiplied by the pressure of the contraction multiplied by the length of esophagus with pressure more than 20 mmHg. The resting pressure of the, or the isobaric pressure, is considered to be 20 mmHg, and that is measured in mm of Hg per centimeter per second. This is what is very important. So normally the DCIs, the normal patient, In a normal patient, the DCI is more than 450. It may be as high as 8000 also. But in case of achalasia, the DCI is less than 100 mmHg per centimeter per second, and that is why it is too low. So what are you getting? You are getting hypertension at the level of LES. Why? Because of acetylcholine acting all the way. There is no inhibitory reflux, so it is not dilating. Aperistaltic activity, low amplitude waveform, and do you know, in the later stages, the entire esophagus will be collapsed. Why? Because of the pan-esophageal increased pressurization. So this is what is referred as pressurization of the esophagus. So how do you diagnose achalasia? Achalasia is no more a clinical diagnosis. Achalasia is a manometric diagnosis. 5 important points on achalasia: hypertensive LES, failure to relax, low amplitude waves, aperistalsis, and pan-esophageal pressurization. These are the 5 important points on manometry to diagnose achalasia. On manometry, the IRP, integrated intermittent relaxation pressure, when you swallow, the mean of the maximum relaxation that happens during the 10 seconds, we take the mean of the 4 seconds. That is what is IRP. So IRP less than 15, distal contractile integral less than 100 centimeter mmHg and centimeter second. This is what is diagnostic of achalasia. Otherwise you cannot diagnose achalasia. Achalasia like symptoms with rapid weight loss in a patient who is 60-65-year-old with a classical short span of symptoms. This is not achalasia, this is pseudoachalasia, and you are dealing with what? Malignancy. And investigation of choice for this has to be manometry. No, it has to be CT scan. This is what is very important. So achalasia is a clinical diagnosis. So let us understand the questions. Comment on the pathology, workup, and the management. Workup I have told you, management, let us discuss the management also, and this is what is very important, very important. So let us quickly discuss the workup and the management. I have already told you the investigation of choices, manometry. And when we talk about the management, you will have to counsel the patient that okay, this is a self-progressing condition, I cannot treat, even you cannot treat. You will have the relief with some agents for certain time, again the things will worsen, again that will increase, again I will change it to some other. So the first line is the medical management. When we talk about the medical management, what are the things that we need to understand here? This is what is very important. We have the calcium channel blockers. What are the agents that we have? We can use nifedipine. That is 10 to 20 then 10 to 20 mg. This is one thing. Along with that, plus minus, you can add diltiazem also. You can add diltiazem 50 mg also. But again, the response is short-lived. The another thing that we need to understand is you can also use phosphodiesterase inhibitors, and when we talk about this, we have something like sildenafil 50 mg. This is what we can use. The most potent among the drugs, they are the nitrates. So nitrates are the most potent agents. This is what is very important, nitrates. But the drawback is the tachyphylaxis. You know what is tachyphylaxis? For the same response from the drug, the dose required is progressively increased. So patient develops dependency to the same drug dose. And along with that, you have the concept of what? Headache. So headache we have, tachyphylaxis we have. These are the certain agents that we use. You can use TCAs, tricyclic antidepressants, to reduce the, you can say, stress. So if the first line, if the medical management fails, then you will counsel the patient for a series of endoscopic managements. Now what are the endoscopic managements that we have, students? We have endoscopic injection botulinum. So what will botulinum do? It will paralyze the acetylcholine sensors or receptors at the level of the G junction. This is how you reduce the tone and hence you increase the things. Always remember, when we talk about injection, botulinum, more than 40% recurrence at the end of what? First year, and that is why high recurrence make them sometimes unacceptable. You have to counsel these patients before you are doing this. Another one is balloon dilatation. What is the concept of balloon dilatation? introducing the controlled tears in the esophageal muscle. So suppose this is the muscle of the esophagus, this is the muscle of the esophagus. Whenever you are putting a balloon and whenever you are dilating and distending it, you are inducing the cracks in this. So induction of the cracks, cracking of the inner circular muscle. What is a big drawback? There could be a possibility that this might cause a esophageal perforation or the esophageal blowout. This is what is. So the induction of controlled tear in the inner circular muscles, this is what is known as the concept. Students, the patient who fail this, you advise them for POEM. What is POEM, students? It is a second space, third space endoscopy. What do you mean by third space endoscopy? First space is the natural lumen, like esophagus, going into the stomach, going into the intestine, or going for a colonoscopy. All these are natural lumens. What is second space endoscopy? Second space is entering into the natural cavities like abdominal cavity, pericardial, thoracic cavity, retroperitoneal cavity. What is third space? Third space means the space never existed. You went into a space and created, like you do hernia surgery between the, you can say between the peritoneum and the fascia transversalis, you create the space of Rediges. That's a third space endoscopy. Same way, you are doing a submucosal entry. In case of POEM, you have per oral endoscopic myotomy. You do nothing. You go endoscopically. You enter into the space. So this is the muscle. Imagine this is the muscle. And let us take this to be the this is the mucosa, submucosa. You cut the mucosa, submucosa, enter into this space and divide the inner circular muscles up to 10 centimeter above the G junction. So 10 centimeter above the G junction is divided in this. The drawback is that there is nothing to prevent the reflux. Nowadays we have ESOFIX which can be complemented with this and reduces. So since this is a rapid fire class, I will not go into much details. And if it fails now, then you will have to go for definite surgery. And what is definite surgery? That is modified Heller's myotomy. Remember, when we talk about modified Heller's myotomy, what are we going? What is the modification? You have to understand the division of the both longitudinal plus circular muscles. Both are divided. So they are divided 5 to 7 centimeter above GE junction, and remember 2 to 3 centimeter below GE junction. 2-3 questions on this. What is ideal Heller's? I have told you this is the level of division. Remember, post Heller's, try to understand fall in tone of LES, by more than 10 mm Hg. This is considered to be what? A successful surgery. This is what is very important. And whenever you are doing this, also understand, go for a prophylactic, what students? Fundoplication. This is what is. Do you know, if Heller's also fail, you can do a re-Heller's. And remember, if re-Heller also fails, then you will have to go for transhiatal esophagectomy. So transhiatal esophagectomy is what we go for. Also, in case of the classical mega esophagus, if you have developed a mega esophagus, in that case also you will go for the esophagectomy. This is what is the classical management of eclasia. So if you see the next image, what is this image? Can you see? You're going right up to the level of G junction and division of the muscle. So you are going for division of muscle. What muscle? The outer longitudinal muscle, and then you are going to go for inner circular muscle. So inner circular muscles, outer longitudinal muscle. So this is a surgery which is known as Heller's myotomy. Why it is modified? Earlier 0.5 to 1 centimeter was divided, now 2 to 3 centimeter below the G junction is divided, and that is the reason for modified Heller's myotomy. So this is all for this session. We will have one more session. I am trying to plan it for the evening, but again I have some commitments in the evening. So I have taken 2 sessions today. I will try to take one more session, and don't worry, today and tomorrow we will be taking multiple sessions so that we complete each and everything. I hope you are enjoying this visual fest. I am trying my level best to cover as much as possible for you all. So still, if your friends have not joined, ask them to join and enjoy this live discussion of the most important aspects of the surgery. So till then, bye. Let us connect in the evening. I'll just recreate the session of the evening and give the link to you very soon. So I have some commitments. There's a serious patient who has admitted. I think he is a patient of appendicular perforation, might need a surgery. That is why I am stopping right now. Again, we shall connect in the evening. Till then, bye bye, bye bye, bye bye. Lots of love.